that we have globally. As you know, we are facing, of course, a huge challenge, a global challenge that appeals us as citizens and also as healthcare professionals, wherever we are in that sector, to change our behavior and practices that some of us learned from school several decades ago. But today, with the challenge that we face in terms of environment, we need to rethink that and to move forward in terms of a more greener practices. So today, we prepare to you some approaches in terms of Portuguese response to this challenge. With us, we have Professor Queiroz e Melo from the Portuguese Council for Health and Environment. Also with us is Silvia Oliveira from Local Health Unit São José. I think that in the seminar of yesterday, Professor Adalberto Campos Freire explained you what is local health units in Portugal and the reform we are facing now. Also with us is Lúcia Dantas from the Central Administration of the Health System that will share us the vision of the Ministry of Health. And later will join us Nuno Babu from the local health unit of Entre do Ivoga, and also Rita Oliveira from CUF Health, one of the major private players in Portugal.
We are going to visit that.
Yes, we will visit also CUF Tejo. It's a new hospital that Rita works there also. Professor Queiroz e Melo is our first invited speaker. Let me introduce him. He's a former cardiothoracic surgeon, a pioneer in Portugal from heart transplantation, and one of the major advocates about the implications of green gas emissions, healthcare and the health and public health, and also a very important advocate for sustainability and waste reduction and circular economy. Is now the Vice President of the Portuguese Council of Health and Environment, and it's a pleasure and an honor to have you with us, Professor. Please.
Vai funcionar? Okay, good morning. Something. Okay, I cannot speak Romanian, but welcome. Let me share with you, I'm in Portuguese. I'd say that I took my basic formation here, my training in America, where I learned that we are the people who can change by looking what to do. We should look at reality to know the truth. Not what is written, what is the reality. And this has been known for many, many years, even before Christ. And so let me also talk talking about healthcare and climate environment impact is not very popular. And when we look at what's happening, how people look at this is from Wikipedia. And when we look at the people who look at Wikipedia in English and look for the year 2019, in blue are people who have been looking at with clicks on health topics. In red, people that with clicks on environment. But when we look at these, people who go to health topics and then look for environment, only 0.18%, 0.18% do it. Whereas people that look at environment and then go to health is 1.12%. So it is not very popular. And here you see what are this is United Nations topics. And you see on the top line, since the 80s, health topics have been always very popular. Environment in green only started by the end of last century to be addressed. But relation in between health and environment only more or less 12 years ago has been a topic of concern. Not very frequent, but it's starting. And we know also that the more you spend in healthcare, of course, the more is the impact. The country that is impacting more, the healthcare is impacting more is the United States, 27%, followed by China and European Union. It's not a surprise. But when we look at that by region, then China, of course, because there are many inhabitants, is the country that is polluting more. What's happening with Romania? Romania is when you look at that healthcare emissions per capita and per country, Romania is impacting less than the average of Europe, the other European countries, whereas Portugal is impacting more because you are spending less money per capita. And when we compare what's happening, those are data from the World WHO, and comparing Romania with Portugal, and we know that Romania, you are expending around 7% of gross domestic product, and Portugal 10%. But to my surprise, and I don't know the explanation, WHO says that 21% of your deaths from strokes and coronary disease are due to health impact. And this doesn't fit with information from Portugal, which I know 10% of our strokes and of our myocardial infarctions are due to the impact of healthcare. And this is surprising because many people think that the most important impact of environmental operations are lung problems and cancer. Particles, they are activators of atherosclerotic plaque. And as such, that explains, and this figure for Portugal, actually for my calculations from our data, is 12%. But okay.
Actually, data from Romania is not
Sorry?
reliable. Data from Romania is not reliable.
I can understand that. Even from Portugal, they are not very reliable. Maybe they are a bit better,
So,
but
I don't know, maybe it's true, but we
Yes,
don't know for sure.
I
Because
prefer not to tell you. But when I say 12%, I did that myself because our data on the environmental impact and nanoparticles and particles are reliable, and the database that exists in America, I did calculations, and my figure is 12%. Another thing that happens in Portugal is that dailies, you work from public health, you know what daily is. That's a limit is just 12 years. And we have healthcare in Portugal is responsible for as many dailies as the COVID pandemic the first year. Meaning by that, if we look only at atmospheric pollution, we get 1,000 dailies per year. But if we look at everything, exterior and interior environment problems, then we are reaching 9,000 dailies per year. Major problem. So we should be aware that significant contributor for health impact is quality of care. It is well known since I was young, you were not yet born, some of you, that there were two famous Harvard economists, Kaplan and Meyer. Kaplan reported that healthcare most significant drawbacks are not the politicians, not insurance companies, but we are measuring the wrong parameters in the wrong tools. And I'm really surprised because, for instance, adverse events in hospital care due to error and faulty coordination are common and lead to diversions. For instance, in Portugal, nobody speaks about it. We only have front page of newspaper, new technique, new thing, and nobody talks about it. It's a major problem. When Margaret Chan was the Secretary General of the WHO, she wrote before leaving that 30% of the problems in healthcare are avoidable in our due to errors. And we should measure what we are doing wrong. And I'm a surgeon, I did lots of problems. And
But the Americans have a project, a reporting system about adverse events and hospital errors.
yes,
Since, I don't know, 2000.
yes, but you know,
It's national.
I know, yes, it's not national, it's by states.
It's national,
But
the
you know,
reports come
there is-
from the whole country. That's what I mean by
That's true,
national.
yes, but you know that there is very important and interesting information on that. Why? Because there is an economic reason or a financial reason
Yes.
behind that.
Yes, I know.
Yes.
I know. If you,
So, insurance
if you report
companies,
this, you get more money.
yes,
I know.
insurance companies do not pay to hospitals where their results for every specific is not within mean or full standard deviations.
I
And
know.
that is particularly in some states like New York, they have to publish the results and so on. But to start that, you have to start building the information. And here, for instance, we are not even speaking about starting to measure it, which is a major problem.
We started something
Yeah.
in Romania, but it's
And of
very
course-
early, like.
Well, Miguel only gave me 20 minutes, so.
Sorry.
So,
But you can, of course, make the question.
so we should be aware that anesthetics are responsible for 1% of the health impact. And the nitrous oxide is a major problem, which is still being used very rarely, but still being used. And in veterinary care is almost 100%. Veterinarians are still using routinely. And they stay for a very, very long time in the troposphere. We don't have time to go to those details. Another pandemic we have are the plastics. And this has been measured, and the most common plastic used for most of the statistics are the gloves. 18% of the plastics are gloves. And we should be aware of this. I'm sure you know what this is a Tyrannosaurus Rex. You are looking at 3.5 Tyrannosaurus Rex. Why do I have here Tyrannosaurus? Because in England, at the the Children's Hospital, the Great Ormond Street, Great Ormond Street Hospital. Two nurses were very impressed with the amount of gloves people were using for everything, like here in Portugal. Everybody puts gloves for everything. So what they did, they went to the quality committee, to the infection committee, they said, those are the conditions to use gloves. Then they went to each one of those departments of that hospital, and that hospital together with 80 vets only. They explained why that they should be taking care of correct use of gloves. They changed that, and after that, they measured at the end of the year how many gloves they had used. In that particular year, they have saved something like 26 tons of gloves. 26 tons of gloves. So they called the program Tyrannosaurus 26 tons weight for 3.5 Tyrannosaurus. Now this program is called Tyrannosaurus Rex 5. It is all over the National Health Service and is being widespread. So here in Portugal, I've been involved in this council because we thought that if we were speaking loans, nobody would pay attention. And so we joined the influencer journalist and another doctor, Luis Campos, who is the president. And we started that Portuguese association. We don't want governments, we don't want politicians of the association. We want only the civil associations. We are now representing 74 associations related to healthcare, scientific societies, hospitals, patients associations, manufacturers, because we want to bring to the civil society the need to think about these topics. In the meantime, I had already started this project, Second Chance, because in Portugal, our waste laws are unbelievable. They are against what the World Health Organization recommends. They were written back in last century, 1996. And for you to have an idea what I'm thinking about in Portugal, everything that comes out an operating is a contaminated waste and should be incinerated. The things that are sterile. And when you change, there is someone fundamentalistic that says, oh, it's forbidden. So I started this project with a non-profit organization, Food Bank, the Second Chance, where we, even though being unlawful, we have been recovering the glue wrap, so this is the textile that wraps everything that comes of the sterilization cameras, and we have been using that to develop prototypes. This is a wonderful textile made of polypropylene. It's a plastic type 5, and we can do whatever you want, either by only doing upcycling, by doing different things like this. This is an anorak that is working in a sleeping bag, unemployed ladies that did that. And, but if you melt that, what it is liquid state, and you put it in molds, you do whatever you shred it, you get pellets, and you do whatever you want. Actually, nowadays there are 3 tons of these that were collected in the period of 1.5 months. 3 tons. Big hospitals, they are being shredded and to be given back to the hospitals as glasses and several others. It's endless, so you only need imagination. And just to let you know, this is a project, urine as organic fertilizer. Urine is a wonderful. So there are always in the north of Africa because of fertilizants. Urine as ammonia, phosphorus, and potassium. and is well known since the Romans. That is a wonderful fertilizer, and we are also using it with agriculture, so we are working on that. Another big issue is the single-use medical devices. And for you to know, like single-use medical devices, that definition is done by the manufacturer. There is not one regulator in the world that has decided that a device is single, one that sells and wants to sell a lot, one that is single use. And I'm old enough, I was in America those days in Harvard, and we got letters saying, well, now this is single use, but don't worry, everything is the same. So of course they didn't believe, they started. And even though, so there is 20 years experience of using single-use devices, not everything, some of them can be used. And for instance, in Europe, 2020, almost 1,500 hospitals have used single-use devices, and in the amount of 32 million of those. Those are the devices that, as you know, have this symbol. In Portugal, we had a very unique law, and I'm telling that story because maybe in your country is similar. The law until 2012 was saying it's forbidden to use single-use devices. And the same law would say later on, but if they are used, then you should follow these rules. There was a major discussion on those days, and finally it was allowed, and for 50 years we had a wonderful experience, published in the Journal of Public Health, showing that single-use devices that are reprocessed correctly on a certified way are at least as good as the original. Ready to discuss that raw figures, they are better, but in statistical analysis, they are the same. It's very easy to understand why they are better. When we use device, sometimes there are mistakes. And of course, those devices do not go to reprocess. This creates the raw data that are in favor of the certified. In Europe, what's happening is you see on this map, because since 2020, there was a new law, European law of devices, saying countries should redefine what they do regarding the use single-use devices. In Portugal, regulatory people are extremely fundamentalistic. They were happy because they could suspend what was going on, going extremely well. So we have no law in Portugal. But in Europe, you see in green what is people who have allowed, the countries who have allowed, in red, the countries where it's forbidden. Romania is there in the south of Europe. You see only Croatia here that allows. And months ago, there are Spain has allowed and France has allowed on the controlled way. And my question to myself, what is going Portugal to decide? So what I did was try to correlate the transparency index of a country and the development index of a country with the decision of allowing or not allowing the use of single-use devices. And I'm talking about that as quality control, certified, CE mark, everything. So the countries who were allowed, they have a transparency index of 76. The ones that have forbidden, 59. The ones that have not yet decided, 57. This explains anything. And the same information comes out from when we look at development index. Countries who allow, they have a much bigger development index than the ones that have forbidden. This, I think, explains many things, social, political, and so on.
But Professor, I don't understand. What can you do? Use devices that producer tells you it's single use. Can you resterilize it and use it
That's what I
again?
mean. There are several types of devices. Type 1, type 2, 2B, 3.
For example, LigaSure.
Okay, LigaSure, a good example. We have Portuguese experience published in the Journal of Public Health. LigaSure is an extremely good example. That we can reuse it, but we have to do it in a certified way because we have to ensure quality, sterilization, function. There are nowadays in Europe industrial activities to make the reprocessing of the complex devices like that, like the LigaSure. Actually, they are either in England or in Germany. And they go to the countries, they pick it up from hospitals, they go to America, they dismantle that piece by piece, then they put it back, they test it one by one, then they give it back to the hospitals.
They give it for
And
free.
for that, they go by half price. The hospitals in there are not hidden costs, half price. Actually, what they do nowadays is on the countries where it's forbidden, they buy those devices. They go there, then they buy the devices, and then they sell it on the countries where it's allowed, because many industry nowadays, they have difficulty in raw materials because of the war.
They sell it as new.
Hmm?
They sell it as new. They sell
You
them
see,
as
Mark,
new.
yeah, no, not that new, they call it reprocessed. See, Mark, actually with the new, actually nowadays there is no longer in Europe what is commonly called processed. Now it's called remanufacturing, because they sell it with a new brand, CE mark, and they are treated as original manufacturing. For you to understand, original industry, they make testing by samples. The reprocessors, they do testing one by one. And that also explains why they have less problems.
This only incentivizes the oligopole producers to keep going,
Yeah. Yes, but look, that's-
making single-use device when they can make multiple-use device. And sterilize.
and there is one reason to favor that is much cheaper to sell something single use than multiple use. That is the only excuse the manufacturers, original manufacturers, they should be obliged to, because I'll show you here, Load Report is a database in America where all problems with devices that are not obligatory notification, they report here. So we can control what's happening. But this is from Johnson & Johnson internet page. It's written, supplying reprocessed single-use devices, J&J is committed to decrease costs, decrease environmental impact, provide better or similar functional characteristics than original manufacturer. So you see, one of the big manufacturers on the internet, because they do that, because they are buying the reprocessors in America. The best answer is that. Okay.
It's a business.
Okay, and actually now the economic gain of this is serving, and nowadays people are no longer in America, they are no longer selling reprocessed devices. They are servitization. What is this? This is leasing. So this way you get your client connected to you.
They give you the ligature for free, and then
You keep reprocessing on the surface, so you don't go to, you don't ask an
Only by the
outside reprocessor to do
device.
it. Okay. For you to have, of course, this is a paper from a master thesis I oriented for the student, and for you it is replacement of aortic valve replacement. And as you can see, I don't know what's happening in your country, but in Portugal, we have several types of waste. So urban waste is in white bags, in the urban is in black. Waste that has to be incinerated is in white, and then dangerous and plastics. But this is a nonsense, and there are problems of triage of the waste. But look, what is not harmful is white, and what is potentially harmful is white.
yellow wheel.
The other are dangerous.
Instead of white.
Petting infected. So, but an aortic valve replacement, if it's not complicated, generates 25 kilos. If it's complicated, it generates 45 kilos, which is with going to the waste, and part of that is not necessary. So I'm fine. We have to stop, but when we think about the future, what will happen, we have to answer to this initiative of the quadripartite memorandum from FAO, WHO, Veterinarian Organization, and the United Nations, where they are calling the attention of everybody that we should look at health as one health, global health. And they invite all people to create new initiatives. And we should think that we have to introduce in healthcare One Health and circular economy, because we, for always have used animals, plants, and soils, the benefit of humans. But now we should also consider that there are quite a number of things that we can give back to animals, to plants, and soils. And what is that? For animals, why should the devices that we no longer can use humans are not used in animals? The veterinarians need orthopedic materials, need makers, need lots of things that can no longer be used in man, should be used in animals. The same applies to plants, and when something is no longer used for this, then the raw materials that are on those devices are all the platinum, endless materials that we discard everything on the soils. We should recover that. They are worse and they have an added value. So what can we do? And when we do those things, we never can compromise the quality of care. We need education, and we need a lot of education. We need to measure what we do. It's not enough to do it, it's to measure it, and we need to disclose and share. And we should always be, if we want to change, we need, like in a menu of a restaurant, doctors have to be involved. We have to be, if people believe it or not. Because if doctors don't believe this process, they will not happen. Quality of care is the first thing, and reduce waste. We should give that an example. If you did something, that is my email. God will do a check. Okay. Any questions?
Thank you, Professor.
But in Portugal, the most respected professions are doctors, nurses, and scientists. So we are really health professionals to be active. what's happening in the country.
I think it's the hospital's job to initiate this kind of circular economy or
Yes.
reuse, or it's another institution's job, like environmental institution. I mean, I think we have enough on our plates as hospitals and doctors to worry about this. I mean, other people should come and take the,
If you speak,
or you can, of course, what you propose with creating some protocols in order not to use so many gloves or masks like we did in the pandemic is very useful. This I agree, but to worry as a hospital, to worry about this, I think is really our job. Or the health system
I can tell you,
who has enough on its plate.
I can explain what's happening in America now. Major institutions, and for MBA, it's my opinion. They have hospitals, they have sustainability units, led by doctors. Their only job not care about patients. They have to care about the other units. People that are opting for that and are respected are not the large people that do not. They go to each one of the hospital units. They speak with them, they look what they do, they get an agreement what should be changed because they change. And most of the things I tell you, they are economically rewarded. Sure, there will be entrepreneurs. Look, we started from zero, now we have industry converting the pellets. Correct? If you allow people to recover the tip of the catheters that have gold, I'm sure that people from jewels will get it, because here in Portugal, as soon as we can overcome some, we have people from jewels interested in that. You have business behind that. They have. And the healthcare, but have the excuse someone else has to do. World will change only if each one of us will change. So someone from outside the hospital wants to do it extremely good, but if they want, we should do it as professionals. I'm sure this is here, they are changing the economy. Deciding that was the time to speak about it and to take action. And in America, every single hospital that has reported those sustainability units, they have reported that the money they have saved from their activity was enough to pay the good salaries, and there was still remaining money. Because if you do that in hospitals, in Portugal, no one is doing that, and the organization of hospitals is impossible. Have that open mind, but if you can do that in hospitals and show, then that will be contaminated the others. It's happening in America now. I'm sure 30% of what we do is waste. It's a lot of money. You know, a hospital like my previous hospital, how much money in Portugal the waste only stayed the waste type 3, eventually contaminated. The other is removed from hospitals by free. Type 3, only that. Hospital like the one I was working before retirement pays per year for waste 3, 1 million euros. 1 million euros for only removing that type of waste. If they save 30%, 300,000 is enough to pay 4 or 5 people.
We need to change from waste management to use waste as a material to a new circular economy. But when you ask if it should be a job or a mission from doctors and all the healthcare professionals? Of course, yes, because as Professor Shaw, medicals and nurses are the most reliable professionals, and they have the recognition from the community. So this movement should begin inside the organizations, top level, bottom level, top level. Fine. Of course, there are other dimensions like legal framework, as Professor explained to us, that are extremely rigid, that don't allow us to have some practice that that can be made, and we can reduce waste and even obtain gains in terms of economical efficiency. And also, we should, of course, at the same level, change behaviors and practices. And that needs to involve all the professionals, training them and move them from the current mindset to a new mindset that have as one of the goals, like quality of care, delivering care, sustainability to healthcare organizations. All of these dimensions should be combined, and that is exactly what Sylvia will show us as a work made by young executive leaders from the International Hospital Federation.
All the topics I told you, they are scientific, even during.
Yeah.
Pacemakers and defibrillators should be reused, and there is public experience of using pacemakers, defibrillators. I'm old enough. I started, we were re-sterilizing and it is in Sweden, until they came into the European Union, 1992. Until then, they were using pacemakers. 12% of the pacemakers implanted in Sweden in 1992 were implantations in Europe. Nowadays, everything is discarded. When we do a heart transplant, nowadays, every transplanted patient has defibrillator, 25,000 euros, which is implanted for sudden death. Portuguese data from 2 or 3 years ago showed that out of those 100%, only have shot because of cardiac arrest, 12%. Pacemakers have measured electrical charge at the time of the last assessment. And they have been explanted. The average waiting time was 6 months. So the first thing we do, or then I used to before, when doing heart transplant, patient is asleep, everything is sterile, open the elbow, remove the pacemaker, go. Of course, I'm not going to reuse it in a 12-year-old boy, 75, a guy of my age. I don't need a machine that is going to last 10 years.
Isn't it simpler that the producer who sold you the distributor who sold the hospital that device should be obliged to take it back and refurbish it? The same distributor.
Yes, but we are still on the point and this still recently was straightforward forbidden in Europe to use implanted devices. So sorry, still in England and in America is the same, but they are recovering. They are sending it to poor countries. It's really good for all options. But that law that was the implementation of the law opens the door to independence. European country that wants to start that now, the law allows that. It's not a European law, it's a country law. So it is possible.
Very hard to sell it politically, to tell that Romanians, because we are poor, we will reuse the materials. You are not entitled to new ones, very good ones. We're telling you that it's okay, there are scientific studies, but you will get reused pacemakers because we are poor.
But as far as I remember, in Romania, they use reusable or refurbished generators. Something new. I mean, I believe there are years since we've banned to use refurbished devices. So it's not very
Yes,
well.
because we have a penal trial. We have a cardiothoracic surgeon who used cardiologist who used
One of the
is facing prosecution.
yes, no, no. One of the most prestigious cardiac surgeons here was my competitor in Coimbra. He was using everything. He was claiming loudly, I don't care if people don't agree, then it put me in jail. But I don't know. He just go to, and he was so prestigious, no one, but he was overdoing, in my opinion.
Okay, you said to be reused, you have to have some kind of institution that will sterilize, will check it, but I'm sure in the absence of such an institution, the usage of such a device is only on the doctor's conscience.
No, but now there is not a reason, because for instance, those companies that are placed in Germany, in England, they do, and it comes to half price.
We need to change the procurement
Of course,
framework
for instance, Portugal
that divides the
do not have the
responsibility
dimension
between
where such a
suppliers
government.
and
Those people go to the countries that we have not implantable. Implantable, they are not yet doing that. It's more complex regarding laws, but the other devices like 2A, only the expensive ones, they are not going to reprocess something that costs euros. Processing things that cost 500 and above. And I don't know how big is the electrophysiology activity in Romania, but here is very active. And National Health, Portuguese National Health Service, we use the electrophysiology card. Say 15 million euros. This is would go to Germany, we will process.
How can another company can assure me that what ligature from Covidian, when I buy a ligature from Covidian, I know what I buy, and they say it's okay, and they guarantee the efficacy and everything, and then another company who, I don't know,
is approved, is certified, it follows exactly the same quality control that the original manufacturer. They do not do
well,
everything.
these are
So they only do
patents. These are patents. Is high-end technology. I'm sure that if it's common knowledge and another company can do what Covidian does, then we can buy everything from China or India, and it's not half price. It's 10% the price. But we don't trust China and India to buy from there because we don't know their quality, and I want to buy from Covidian. I think it's very tricky. It's not very
you buy from
straightforward.
Covidian because Covidian has CE mark.
Yeah.
And those companies I'm speaking about, they are all CE. They have the same quality control. And all the studies published document what I'm saying. But it's not new. Germany, that's why they are rich. The poor countries, they follow this kind of opinion. and we destroy it. That's what our countries are doing.
Let's not count.
It's one of the parts.
Yes, it's a small example of what we are doing.
Thank you, Professor.
Okay.
Thank you so much, Professor, for being with us again.
Thank you.
Thank you.
Well, let's move forward before we make a short break to Silvia Oliveira. She's a young manager, also a former student from this school. She was a young executive leader from the International Hospital Federation, and last year they dedicated one work group to sustainability in the healthcare sector. And she will share with us some of the guidelines and proposals to young executive leaders find and identify as starting objectives to all managers around the world. So, yeah, thank you so much for being with us. Let's change your presentation.
Good morning. As Miguel said, my name is Silvia. I'm a deputy administration board and hospital administrator. And last year I was a young executive leader. During 6 months, I worked in this topic, best practices that healthcare leaders can embrace to create sustainable hospitals. I will start with the program, then talk about climate change, the 10 best practices to create sustainable hospitals, and at the end we'll talk a little bit about best practices in practice nowadays. So what is a Young Executive Leaders Program? More or less at this time of the year, I applied to this program, and when they are selected, they attend a series of master classes, in my case 8, in key healthcare leadership areas like sustainability, big data, telehealth, cybersecurity, human health resources, and health finance. And at the same time, in small group work, we have the opportunity to share our insights across our global community and about a topic, in my case was sustainability. And it started in April and finished in October with the graduation of the Yale Alumni Network at the World Hospital Congress that last year was in Lisbon, and this year it will be at Rio de Janeiro, Brazil. So who can apply to this program? Professionals that work in healthcare services, hospital association, or Ministry of Health under 40 years old. And also professionals who want to develop their leadership skills while learning from international experiences. So, climate change is currently the greatest potential threat to the human species health. The healthcare sector, whose mission is protecting and promoting health, is a major contributor to the climate crisis, with more or less 5% of net global emissions. And the healthcare sector has an important role in reduce the carbon footprint. So incentivizing sustainable behaviors can create a positive feedback loop. And healthcare leaders has an important role to reduce and to implement sustainable behaviors. So, which is the 10 best practices to create a sustainable hospital? First, support the healthcare workforce to embrace sustainable practices. Hospital leaders can empower employees to support sustainability efforts through education, training, and advocacy. Participating in community projects and supporting local sustainable business helps amplify the impact of sustainability initiatives. 2, establish an organizational culture of sustainable healthcare by appointing and supporting chief sustainability officer, develop a clear and comprehensive sustainability strategy, and establish internal sustainability committees. 3, embrace technology and innovation that supports environmental sustainability by prioritizing environmental sustainability and energy efficiency by integrating technologies, including digitalization and smart technologies, telemedicine and virtual care, cloud computing, and wearable devices for patient monitoring, and invest in technologies such as medication management system and digital imaging and maximizing long-term impact. 4, adopt environmentally conscious regulatory frameworks. Organizations should align their efforts with existing frameworks to advance their sustainability efforts. And on interest, the Joint Commission International is collaborating with the International Hospital Federation, Geneva Sustainability Center, to develop environmental sustainability standards for international hospitals around the world. 5, implement optimal waste management practices. Hospital leaders can think about improving waste management through an administrative focus on reducing, reusing, and recycling with environmental awareness, while managing more complex wastes through safe disposal strategies to reduce environmental impact and keeping with the best practices outlined by the World Health Organization, such as reduce the volume of waste generated and improve waste segregation, destruction, and disposal practices. 6, optimize supply chain management. Most of the healthcare's climate impact through supply chain related emissions, accounting for approximately 82% of healthcare emissions. This impact can be mitigated by assessing the carbon footprint of purchasing products, leveraging digital tools and technologies, and identifying synergies with other purchasers. 7, maximize system efficiency and embrace sustainable practices by engaging with choosing wisely campaigns to reduce unnecessary tests and treatments, reduction of unnecessary pharmaceutical use, substitute high emissions products with more climate-friendly alternatives, and incentivize the production of affordable green climate-smart medicine. 8, reduce high emissions healthcare-related travel. Transportation, including business travel, operation transport, and supply chain logistics, constitutes about 7% of global healthcare emissions. Leaders can start by identifying where healthcare climate solutions may be more cost-effective than business as usual, and invest in this, like electric vehicles, virtual care, digitalization of services. 9, rethink the concept of green hospitals. This consists of practice of designing, constructing, operating, maintaining, and removing buildings in ways that conserve natural resources and reduce the pollution. Investing in green design has several benefits for hospitals and positive impacts on health and well-being of patients, staff, and visitors. And the last one, enhance patient awareness. Partner with patients to achieve sustainability goals by integrating sustainability messaging into patients' communications by providing information about eco-friendly practices and visibly highlighting the organization's commitment to sustainability with their premises. Additional to the article, we did an infographic that's basically resume all the information, and they are the article and the infographic are available in the site. So I bring here 3 examples of best practices in practice nowadays. And the hospital proximity pharmacy at Wellies São José in Portugal, that you visited 2 days ago, was implementing in 2020 to facilitate the access of hospital medications through local pharmacies. And preliminary analysis estimates these savings at more or less 270 euros per patient per year, and a reduction in carbon footprint corresponding to 70 kilometers per trip for dispensing of drugs. In Switzerland, the Geneva University Hospital has tackled the climate impact of high emissions healthcare related travel through a multifaceted approach. They work with local public transport operators and the Swiss and French railways to offer its workforce early travel subsidy, reserved parking spaces in streets near hospital buildings for 2-wheelers, and set up bike sharing and car sharing subscriptions, and facilitated workforce discounts on bicycles from local sales partners. And the last one, the Hospital Sírio-Libanês in São Paulo, Brazil, which has implemented a lot of different initiatives, including optimizing waste management, implementation of green design practices, including solar power plants, expansion of low greenhouse gas emission transportation, and preferential recognition of suppliers with sustainable practices with the supply chain. Conclusion, there are several practices that healthcare leaders can embrace to create sustainable hospitals, and healthcare leaders need to create a sustainable conscience to ensure the optimal efficiency of available resources to benefit the health and all human beings. So healthcare leaders can make change in their organizations to support hospital sustainability, and it should start today. Thank you for your attention. If you have any question, please let me know.
What do you think about this roadmap? That's lots of things we can do.
It's a lot.
Any questions? These are the proposal from the beyond the executives. Comments?
I think that, it's interesting. It's very, something that you should think about, but it's very difficult to, let's say, implement the change.
I think the first step
In this generation.
No.
In my generation, let's say.
We are the
Maybe
ones that have the responsibility to leave,
Yeah, but
leave the basis to the generations. Because we are responsible for the actual reality.
I'm speaking from the Romanian perspective. I don't know.
The reason is when you have everything in place, when you have a functional system, refurbished infrastructure, investments, yes, you can start thinking about fine tuning, and this is very honorable. You can tick a box. You can access funds because everything every fund is oriented to gender equality and this kind of green But when you have structural problems with infrastructure that wasn't refurbished since the 1950s, when you have investments, an investment need that is 5 times your budget, have the lack of personnel and big issues to resolve, these ideas sounds good, but for us, I mean, for me as a cynical person, is not something. Okay, we should do what we can, as we resolve our structural problems to address some of these issues. But it sounds, yes, hard to think of this when our country is very green compared to others. When you know that the impact of reducing 70 kilometers of its, I don't know how, micro, it's a micro impact. Yeah, when China is polluting and India is polluting, and unfortunately, forcing this, because it's very good if it's an advice and we can learn and we can apply. But unfortunately, this politics is forced on nations that are struggling, and instead of addressing our structural issues, we are forced to address these things. So you cannot address environmental issue when you are hungry, or when you are when we have structural problems in the system. Yes, so this should come as an advice and guidelines, but should not be forced. Funds from the European Union should not be 50% on this or else. Yes, so everybody, we have to first, we have big differences between countries in the European Union. Us from the East have a lot of catch up to do. So we first have to reach your level of development, and then, yes, we can have similar objectives. Yes, so that's why I'm cynical, and I love what you presented, and it's very good that something can be done. But from my perspective, when I know what we have to do in our health system and what our priorities should be,
This is not yet a priority.
No,
Well, but
you cannot
since
say
it has
like
so
that.
many-
I'm not as pessimist as my colleague, for example. But we really have to think about infrastructure. For example, we Romanians would like very much to have new cars, modern cars. We are like crazy about this. And we would like to buy electrical cars. And we started already. And the market is inexpensive. It's growing, it's growing. But we don't have plugins.
I think in Portugal it was more or less the same.
we are still moving
It's all
forward.
about infrastructure.
This is a learning process to all of us.
You comply with this idea of changing fuel on an electric, but what to do with it? And you cannot change this at a personal level or a small company level. You can have, let's say there, but what about home, or what about where you go in the country?
Obviously, regulations, kind of regulations make sense when you have the human needs
Yes, covered.
Yes. So it should start, but you should start in one way, and you should start to make difference, like healthcare rules in our institutions, in our country. And in my opinion, in my personal opinion, we should start finding chief sustainability officer in each institution. The first step. And then the things, the other recommendations will start to, but we have a problem that's said before, like procurement or legal framework. And as I said in the last session with other colleagues, public hospitals has a different legal from private hospitals. And they can buy or choose a supply more sustainable, but in public we have some rules that can't allow us to do that.
The lowest price.
Yes. Yes.
To introduce changes in the legal framework and
Why
program
to buy more
framework
expensive and
to make
have
a
less
positive
patients
discrimination
benefit
to
from,
more sustainable suppliers.
Just to be green, we should buy more expensive and less patients should benefit.
That is one point of view.
Yes, it's a very pragmatic point of view. Okay, this should be recommendation. Unfortunately, they begin not to be. They begin to be enforced. They begin to condition funds. This is a big mistake. And it will backfire severely in the following. So, yes, we should be very, very careful because the science is not 100%. And okay, I'm not saying
You are a non-believer about climate change?
not a non-believer. I can say what I want. No, I'm not afraid that I will be hanged in the public market. Fortunately, in some countries, it happens. If you speak your mind on something, you are crucified. Yeah, and this shouldn't happen. Yes, we should take all the recommendations, do what we can, but it shouldn't be enforced. It shouldn't be enforced because we have different problems. We have a war on our border. You have the ocean and 19 degrees. Not that Portugal, you are not, I'm thinking other countries are enforcing this, not Portugal.
Yeah,
You are-
for sure.
You are very
It's not
common sense.
Portugal. We
You
are only
very
sharing
common
our
sense
practice.
people, and I like you. I love you. But we should be careful because it will backfire. Believe me, it will backfire.
And what about the suggestion that Sylvia made about creating a figure for someone in your organization that
We don't have
think
enough
about
people.
opportunities?
We don't have enough people. We have lack of personnel. And a sustainability officer is a position that we cannot afford. Yeah, and his activity will be not regarded. I mean, colleagues that understaffed, that have to deal with much more patients than they ought to be, should listen to the sustainability that will present them some green ideas. It's hard to do it. No? When we have time and we work in a very nice environment, everything is refurbished, enough personnel, yes, we can think of optimizing green ideas and sustainability. Because when you have structural problems, when you're hungry, as I said, yeah, it's hard to think. This is why the European Commission should not enforce every country. Because we first need to reach level of development, similar level of development, and people who have welfare care about the environment. People who are hungry won't care about it. So we first should care, have everybody filled up and not being hungry, and then they will care about the environment. I think it's a different approach, and it's much more healthier than enforcing, hungry people to find union. As a recommendation, they are perfect. They will have their time when other more important and pressing matters will be resolved. This is for sure. I mean, I have a sincere discussion with you. There is a safe environment. But
the same problems you have.
We should be sincere about this, because otherwise, yes, we present nice and very nice. Everything will be good. We will all dance and cheer, and the sun will be up. And we shouldn't be. I mean, this.
It's a little bit like you have a patient with a wound that's bleeding. And instead of repairing that wound, you think of how to change the gloves, or if you follow the circuit, and he's dying until you do all these things, like, quality of care according to things like that. But you should repair the bleeding, and after that you can.
It's not like it's your decision.
No, I know it's not decision. I know,
it's my
like that.
It's like the state is telling you, instead of stopping the bleeding, you should first make his eyelids. Yeah, enforcing these policies. Yeah, when there are other pressing matters.
We have priorities, not only in healthcare systems, around our policies. For sure, sustainability and environment concern should be in our agenda. If we are capable to combine the two, that it's the perfect map that we should follow. For you, as manager and leaders in your healthcare system, you must have it in your agenda. It's not a priority for us, that's a choice, but you should not forget that it's a priority that you should address if you have possibility. And one of the major responsibilities you have is, of course, to drive that change. Well, it's not the first point in your agenda, but you should have it in your agenda.
Yes, but it's my agenda.
At some level, you will have the opportunity to change and to implement. But don't forget that it's, of course, we can discuss if this is priority for you. If they will give funds to implement it, if it is an approach that is a positive discrimination, endorses to move forward to that, or if it's not. But as managers and leaders, you should not forget this point. And these are some guidelines. Of course, some of them can be implemented by the responsible for sustainability or a working group or organization. But there are other proposals that are more focused on supplier in terms of management resources. But you should have that in your mindset, and of course, if it's possible to move forward. In Portugal, we are on the beginning of this process. We are on the beginning because we don't have yet the figure
We are
of the
still
chief
hungry.
sustainable officer in all our hospitals. Not, we don't reach that yet. We are starting to discuss it, to making healthcare decision makers and professionals to be aware of the responsibility they have out there. Our legal framework is still not allowing us to reprocess devices. We don't have the possibility to buy from suppliers that have a trademark associated with sustainability, to buy the cheapest one, sure. But I would like to share with you, and Lucia will share with you, what the central administration of the health system are doing in terms of their program that they call Eco Saúde, Eco Health. Lucia is responsible for the Eco Saúde program in Portugal. I don't know if you can make a break or if you continue.
Should take a
A small break, and after Lucia will share with you the experience from Portuguese healthcare system, the program Eco Saúde, that tries to manage the energy and the resources in terms of monitoring the performance of all the. Okay, that's
didn't make it a strong way presentation, but I think it's a discussion we all have.
We can restart now.
Yes, of course.
Lucia, thank you very much for being here.
As Miguel said, my name is Lucia, and I'm an engineer working in the facilities and equipment at the Central Administration of the Portuguese Health System. That is an entity that is part of the Portuguese Ministry of Health. And we have a program called EcoSaúde program, Environmental Sustainability Program at the Portuguese Ministry of Health. And this program was created to start treating this issue, the sustainability issue, in all the entities that belong to the Portuguese Ministry of Health. It was not only an effort from the health sector, but from all the public administration that started implementing some sustainability programs and measures, and in the health sector, public health sector, we started this work with the EcoSaúde program. And what is this program? Basically, the objective of the EcoSaúde program is to pursue the political goals in terms of sustainability. We have a national energy and climate plan. We have also a national roadmap for carbon neutrality 2050, and this program will try to pursue the goals of these national plans in the reality of the Ministry of Health. So, for you to have some data about our impact on the environment, in 2020, Portuguese NHS hospitals were responsible approximately for about 25% of our energy consumed by the public administration buildings. The NHS hospitals also spend about 4.5 million cubic meters of water and produce around 16,000 tons of waste. 16,000 tons of waste, yes. And to be more sustainable, we have some goals that we must complete with these goals until 2030. We have to reduce our energy consumption. We have also to reduce our water consumption. Energy consumption must be reduced in 40% by 2030. Water consumption must be reduced by 20%. Material consumption reduction by 20%. We also have to improve the amount of renewable energy consumption and the weight of the energy consumption through to renewable sources on the final energy that we consume. We have to reach 10% energy consumption supplied through self-consumption solution like solar, based on renewable energy sources by 2030. And how are we going to achieve these goals? We have since 2012 and 11, we have been implementing some sustainability campaigns that are awareness actions. to try to change the behavior of all the users of the buildings of the Ministry of Health. This campaign is based on some templates with messages about reducing consumption of water, consumption of energy, and also reduce production of waste. This is something that we used to change the behavior of the people, and they can also put their actions in place in their own houses. And we have also a good practice guide for the health sector that is a document with a set of measures that imply low cost investment and also low complexity. This guide, the good practice guide for the health sector, the measures in the guide had to be implemented, must be implemented in our entities, in our hospitals, and there are no excuses for don't do it, but because they are measures of low complexity and low cost. I don't have here an figure of the guide, but in the final I will share with you a link to the place where we have the guide published. But when we talk about measures that can really make a difference, measures that need high investment, this is where the problem is, because our hospitals are are dealing with constant financial constraints, and for make improvements in our buildings, in our infrastructure that bring some energy efficiency. We have to use external fundings, and fundings that came from the European Union. Our hospitals have been very efficient on doing this kind of on taking advantage of this. And for example, in the past years, we more than 100 billion euros were channeled to Portuguese Ministry of Health facilities to improvements in about energy efficiency, to improve buildings and promote buildings more efficient buildings. Now we are also implementing another. We are implementing the support for the recovery and resilience plan, and until the moment, more than 46 million euros were channeled also to our healthcare facilities. We also have another tool that are the energy management contracts. These contracts will be made by the energy service companies and the hospitals. The aim is that the energy service companies they will implement improvements in the buildings, new systems, new equipments that promote savings in energy consumption, and the savings, the money that is saved is I don't know the word. A part of the money is for the hospital, and another part is for the energy service company. And through this, we will be able to get funding to implement these energy efficiency measures. About the organization of the EcoSaúde program. Basically, we have Energy and Resources Manager Network is a network of energy and resource managers. Each hospital has a person responsible for the implementation of the program locally. Each hospital has an energy and resource manager. Each local health unit has this kind of figure. This person is not, his job is not only this. He's normally an engineer working in service in the facilities, but he is also responsible for the implementation of this program. He has to promote implementation of measures, sustainability measures, and also he has to monitor consumptions of water, consumptions of energy, waste production, and send the data about it through the central administration of the health system. And we, with the data collection, we produce monitoring reports and other kind of information to see the evolution of the program. The organization of the health of the Portuguese Ministry of Health is now being under some changes, a reform, and there will be some changes also in the EcoSaúde program regarding to this reform. But we will maintain the essential of the program. So we have reports, semi-annual reports, where we show the trajectory of the different healthcare entities regarding the targets, the reduction targets. For example, we have here in green those that are being able to complete with the targets. In red, those that are not yet complete with the targets. We did this semi-annual report since the beginning of the program, and they are really useful.
They are independent.
Do
you think it's reliable? What happened?
Was an exceptional situation, and we saw that there was big, a really big consumption, and mostly we saw that in terms of waste, we produce a lot, much more waste related to the disposable masks and other equipment that was necessary. But this data is from the pandemic period, 2021. We have also a ranking, energy and water efficiency ranking, that we use to benchmark marking of our hospitals, of the health system. They can use it to make some benchmarking with other hospitals, see how they are in terms of efficiency, is about energy and water. We have a platform, through which we receive all the data about the consumption of water, energy, about the production of waste. Now we will migrate this monitoring to a national platform where we will have information about all the public administration, not only the hospitals. And this is a work that is being done by our energy agency. Now I will talk about a specific project. As part of our work in the EcoSaúde program, we identified the need of understanding and calculating our footprint in terms of greenhouse gases. And to do that, we accepted the invite of the Healthcare Without Harm organization, and we have to implement a methodology that we will end with our with calculation of our footprint. And it was very important because they have specialists. They have expertise on this field, and we don't. And we make this calculation to 2040, and using a methodology called input-output analysis. And the results we show the results in these figures. When considering the entire Portuguese health system, covering public and private entities, we see that our footprint represent about 5.8 of the total greenhouse gas emissions at the national level. When considering only the private, the public healthcare entities, they represent, their emissions represent about 3.7 of the total national. When looking to the sources of greenhouse gas emissions, we see that the greater part of the emissions are indirect, and they result for the use of electricity and from the supply chain. They result of all the activities related to the supply chain, to the acquisition of goods and services. 81% are indirect emissions, and they cannot be directly controlled by entities because they result from buying service and buying products. 14% of our footprint is directly controlled by entities because they are a result of the combustion related to boilers, combustion on the vehicle flat, and it's easier to control this kind of emissions, the direct emissions. But unfortunately, the most part of emissions are indirect. When looking to the indirect emissions, we see that are two main sources of greenhouse gases. Associated with the procurement of chemicals and with the procurement of pharmaceuticals. And these results show that these are two important hotspots of emissions that have to be need some kind of solution that unfortunately that doesn't only depend on our action. And about the roadmap to zero emissions by 2050 is a really difficult challenge to meet, because it really doesn't depend only in our action, but we have some special competitive points for our NHS hospitals, and some technological improvements in order to converge to net zero. So it's important to boost the production of electricity via renewable sources for self-consumptions like the photovoltaic, the micro-generation. We need to increase the efficiency of HVAC systems. There are now also legislation that allows that trying to make the hospitals implement this kind of measures. We also have to develop a connection between equipments that use energy to centralized technical management systems that control this kind of equipments, electrical equipments. We have also to improve the quality of the utility consumption monitoring. We are now working for the development of the EcoSaúde program. That is the web page that we use to monitor our consumptions. We have also to encourage the healthcare entities to switch off the car fleet to electrical technology. We, as we saw by the graph of our greenhouse gas footprint, there is a need for an integrated vision between the technical and the clinical components. There are many parts of our greenhouse gas footprint that depend of the clinical components, like the emissions related to anesthetic gases, and emissions related also to the metrodose inhalers use. And we have to mitigate emissions related to the buildings, to the energy consumption, but also those related to the procurement and to the choices of the clinical components, the choices of the medicals, the pharmaceuticals that we use, the anesthetic gases, the use of anesthetic gases. And we conclude that chemicals, the consumption of chemicals and pharmaceuticals represent more than 40% of our greenhouse gas footprint. Unfortunately, the reduction targets that we have in EcoSaúde are not related with the procurement. They are related with energy, water consumption, and waste production, and therefore our targets are not able to influence those emissions. And also the great majority of our indirect emissions related to the supply chain. But this study gave us the opportunity of acknowledge this fact and of recognizing that we have to work on this field, on the procurement field. We have to search and for more sustainable options and to work in this challenge. So we recognize that decarbonizing the supply chain of the public health sector is essential to meet the sector decarbonization target trajectory created in the study that we made. We cannot only think about the emissions, direct emissions that we have. We cannot only change our vehicle fleet. We have to think about the goods that we buy, and because those emissions may not be here on our hospitals, but they happen somewhere else in the world. Maybe in China, maybe in India, but they are also important and they have to be treated. And it's a work in progress. It's a work that began a little time ago, 10 years ago, and we know that unfortunately, to the current situation, it's not the top priority, but we have been able to do some work to do, and I see that the awareness is rising in our health, in the healthcare professionals, and something has been happening.
Thank you, Lucia.
Thank you, Miguel.
It's a great work. As you see, 10 years, and we are still on the beginning. Right?
Yes.
That the knowledge that we generate with this kind of approach, it's starting to give some results.
In the unit where I work, this work is only a part of our work. We are unit that works in the normalization of engineering solutions and architectural solutions in the hospital, in the public hospitals. But we have our time is not only for this, but we try to give some of our time to do this work, and we are trying to do our best. If you have some questions, please be free.
You said something about the reduction, at least this was the target, 40% of the
Energy
consumption. When you speak about energy, you mean all kinds of energy? I mean gas, electric, everything like that?
Yes.
Okay. And you said that you are going to implement some easy, less costly money solutions for the hospital. Can you give us an example what these kinds of solutions can be?
Yes. Our guide is available in our webpage, and there are a lot of measures in the water field, energy and waste management. For example, for energy, using devices that
Switch off the light?
they light
Does
Yes,
it
yes.
like on and off
Yeah.
according to the movement of
Yes,
that person?
yes.
Okay.
These are simple measures. They are not really, it's not a high investment measures, but they have
And you
important.
calculated that it's important to have something like that they reduce.
Yes,
They represent a
yes,
contribution to
because
reduce.
there are some places where people just passes by and goes like we have here, the exit of the room, and it's
Close the light.
exactly.
Are you okay with this
Yes,
slide?
yes, 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 okay.
We just now become aware of.
They can do some difference, and but there are a lot of measures. I don't remember all. Also, I'm not the electrical engineer, but there are some measures that only electrical engineers can talk about.
Because I think, for example, in the Romanian hospitals, the hugest consumption of electricity is in the OR, is in the radiology, is in the
Yes.
laundry, is in the kitchen, because we have lots of the old hospital, they have their own laundry, their own kitchen.
And this is the more difficult.
And if you want to buy equipment, there are less consumption. You mean new equipment, they consume less electricity.
Yes.
That's why we were talking a little bit earlier. Yes, we
Make
can think
wise
of things like
choices
that.
basis
Yes, but
that can
it's
have
very
also
expensive,
impact on
this kind
the
of
consumption.
When you change equipments to the age of the equipment, or because the equipment is as a problem, we can change by a new equipment
of course,
with more
that's for
efficient
sure.
equipment.
Yeah, that's for sure.
But to implement high investment measures, you need funding. And to do this, you have to use, for example, European funding or energy management contracts that we I talked about this kind of contracts that are done between the hospital and an energy service company, and savings are split between the parties, but the measures that can really make difference need high investment.
Yes.
It's true. It's true. With this guide that we have, the practice guide, they can make some difference, but they cannot solve the problem. We have to be realistic about yes. We have to. It's something that we cannot do from night to day.
Exactly, you have to change
With lots of time available.
2022, after the onset of the war, invoices for gas and electricity in Romania went 3 to 7 times. And it was a huge problem. I mean, hospitals couldn't afford to pay them. We did at the Ministry of Health an analysis of comparison between what were the bills, and try to find solutions to help them pay the bills. So, yeah, it's a good idea to reduce the consumption as much as you can. But when you have also these fluctuations in the market of electricity, and this is mainly due to the stress that we're taking to change towards more sustainable energy sources, we will suffer. So it's going to be a painful process.
Yeah, but when the subsidizing of the electricity will disappear one day, probably you have to do something. You have to do something.
Well, Ceausescu, during the communist era, we were very efficient. We had only 2 hours of
But this is not.
television per day, and
That is not efficiency.
the lights would be cut off for a few hours every day. So we can do that.
This is
We can
not-
stay in the cold and.
That is not
It
efficiency.
was not efficient in those days because actually we had one of the very energy consumption industry and very inefficient. And basically they decreased the heat in the houses, so it was not useful. So it's just a
It's
kind of
No,
propaganda.
it's the perfect example. So you suffer in the houses, the citizens, for nothing. So we try to do it in the hospitals where you need electricity. To reduce 40%, it's unreasonable maybe, because you don't know, you had some indicators with the surface, but you have to be much more granular than the surface.
We have,
Because
we have also.
there is one chronic psychiatric hospital, or I don't know, who functions till 1 o'clock. The doctors are there and they go. And another is an emergency hospital who has permanence and MRI and.
Yeah, but when the energy will become completely free and will become one day, because I don't think we will have subsidized electricity forever. And I don't think the cost of the electricity will increase so soon.
No.
So I believe we should have a more. So I think we should think also to decreasing the energy consumption. It's not only
I
saying
believe
it's
we
expensive to
will
change.
go towards free electricity for everybody. I mean, this is the goal. The electricity shouldn't be limited. I mean, if we don't do that, we will go to the dark ages. So this will happen in the future. Electricity will be available to everybody. This is.
Yeah, but the consumption is not bad.
Until then.
If we have solar panel everywhere, we will have free electricity for everyone.
Well, it's a dream that it's not achievable for sure. Because even solar panel are of course under the control of some supplier, no?
Agreed.
Well, we have a country that have more than 300 days of sun.
Even
Here,
for Romania,
And we
it's
don't have
very
free
efficient.
electricity.
And
Even
don't
for
bring
Romania,
this.
the solar panels are excellent. If we speak about a home,
Yeah,
they
for
didn't pay electricity
for
in the
domestic
last 3
consumption,
years.
yes.
But if-
facilities like hospital organizations.
You just have to have
We
more.
need to combine
The
several
technology will evolve.
resources of
The
energy.
technology will evolve.
Yeah.
This is for sure.
But
So
we-
batteries will evolve. This is the main concern. Because the grid doesn't support the solar panels now, or if you move to electric cars, right now, all of us, the grid will fail.
It's
So
an ongoing
it's
process
ongoing,
until
and
we achieve
technology will
100%.
evolve. This is, whoever thought 10 years ago that we would have electric cars with 1,000 kilometers autonomy. So
Technology will evolve
Yeah.
and will give
little
the
by little,
responses
but
we need.
it will cost money, of course, and we should.
And time.
Uh,
I'd like to see that this is in your agenda, so you are engaged with environment
Yes, but
sustainability.
my motivation is economy. Is not,
Both of the reasons are
But
valid.
sometimes
they,
parts,
they do.
economy
they
and
can-
sustainability can
I mean, from the Romanian perspective, it's very good to have local data. And have kind of multidisciplinary research between, I don't know, medical universities, hospitals, and engineering, and so on, find locally solutions based on local data and link this sustainability at the environmental level, also sustainability and so on. So I guess people will have local data, and this is something we miss. But when you have local data, people trust more. So you have to do the first thing, do some research.
I mean, we can, it's useful what you have that data, you know, we did
It
it
is
manually to, when we had this problem with the bills, so we asked all the hospitals, give us your consumption, and we took an Excel and compared it. But it's useful to have this data and to analyze and to see where you can improve. I mean, one hospital may have a very good consumption, and you go there and see what they do, and then promote it as a model of good practice to other hospitals, similar hospitals.
Yes, so the ranking is made between, we don't mix up the different kind of hospitals. For example, cancer centers are in a special group because they have equipment that have high consumptions, and because
So-
that the ranking is ranking in different groups of
Yes, for
hospitals.
sure, 40%
And we
for
cannot
everybody
compare-
is not achievable. I mean, 44% undiscriminatory for everyone is not achievable. And you should have the baseline, you know, maybe some were already very green. I mean, a new hospital is already efficient, and if you ask him to go another 40% down, he won't do it.
Almost
Yeah,
impossible.
so
Yes.
it's difficult to set up these targets, and so you have to have flexibility. Okay, it's a target, but I don't think you will punish someone if they don't
No,
reach the
no.
40%.
There is no punishment. If you have another questions or in the end of my presentation, there is email of the program. I think Miguel is going to check the presentations.
Let me see if our speaker from Interjuli Volga is already with us. Dr. Nuno Babo está conosco.
Sim? Consegue ouvir-me?
Perfeitamente. Dr. Nuno Babo is an anesthesiologist from local health unit Centro de Voga. This organization is an organization that have a very defined plan to move to a green hospital, now a local health unit. So they are now recognized internationally with the International Hospital Federation for several projects. And Dr. Nuno Babo will share with us their project that has been awarded recently in the International Hospital Federation that takes place here in Lisbon. And I think last year also in Dubai. And it's a project that have their focus on the pre, intra, and post-operatorium circuit of the operating room. So, Dr. Nuno, thank you so much for joining us. And the floor is yours. Thank you.
We share. A little bit. All right. Are you watching the presentation?
Yes, yes. You can put it on the screen.
I'm trying. Is now? Okay. Good morning to everyone. As Dr. Miguel said, my name is Nuno Bava. I'm an anesthesiologist from Local Health Unity Entre Douro e Volga. And I'm here to talk a little about sustainability in healthcare. That is an issue that is well care in our hospital. I want to make this go. I'm not doing this thing right, sorry. A little bit back. Okay. We are a national health service composed by 3 hospitals in the district of Aveiro with 380 beds, more than 20,000 surgeries a year, and more than 230,000 emergency episodes. We are well aware that healthcare has a huge impact in environment. Healthcare has become one of the fastest growing industries in the recent years. So the healthcare sector is responsible for almost 5% of the global greenhouse emissions. And if we compare this to a country, we will see that it will be the 5th largest polluter on Earth. As we are aware of this, the hospital, all the hospitals try to make a program that will try to fight against this reality and do as much as we can to help improve this issue. So we know that almost 5% of the polluting sectors, one of them is the healthcare sector, and the biggest areas of consuming is the energy consumption, transportation, product manufacture, and use and disposable. And as I said, aware of this, we understand that we need to change our way of working to produce a more sustainable healthcare that we provide to our patients. We create our strategy that is come bottom up. Not only the top of the pyramid was included in this project, but we try to implement all across all employees of our hospital and try to commit them to the project and try to make them think these kind of issues and try to collect the best practices and implement them in all the services. And aware of that, the hospital creates a group for identification and implementation of sustainability practices, and it called them Local Health Unity Entre Douro e Volga, a green hospital. And that this group creates also and try to identify among the hospital the people that we call sustainability warriors in every services, and they are responsible to collect ideas and to spread the word of which are the projects that the hospital is trying to implement. Because we all know that the change starts in people's will. If we bring the people to our ideas and to our projects, the results will be much bigger. Which are the main goals of this global project? We want to create an environmental conscience in the people of our hospital center, to promote and train staff for environmental sustainability, to reduce the production of waste, to promote reutilization and recycling, and the area that we specifically, I as an anesthesiologist and the most of the physicians that we talk about, to develop more sustainable clinical practices. And I will focus a little bit more in this main goal, but I'll try to check all the other goals that we include. As Dr. Miguel said, we work more in the perioperative period with the patient, and we try to implement more actions in the preoperative, in the intraoperative. We think that is the part of our work where we can make more difference. So in the preoperative period, we sit and we think, what can we do to change our practice that can be more sustainable? And we try to understand. In our services, we provide consultation, anesthesiology consultation to every patient that is proposed to surgery. So we think, what can we do in this field that can create a more can be more sustainable? So we think, and we are implementing a teleconsultation in anesthesiology. This program started in half the year, the 2023. Since then to now, we make more than 200 teleconsultations, and this action avoid more than 140 hours of car travel, the consumption of more than 500 liters of fuel, and avoid the emission of more than 1,000 kilograms of CO2. In our universe of consultations is more than 13,000 consultations a year that are eligible through this kind of program. So we estimate to reduce, when this fully implemented, to reduce more than 70 tons of CO2 emissions a year. Also in this field of preoperative actions, we create protocols of the way we ask complementary means of diagnosis in the preoperative period. We want to make full that known word, that is the routine, preoperative routine. We want to make them full, and we create protocols that take in care the surgical risk and the physical status of the patient. And we try to complement them, analyze them, and only ask the complementary means that are really needed in some surgeries and in some patients. With this project that we only started to fully implement in half the last year, in half a year we already reduce more than 3,000 SEGs that are asked. And even in the blood test orders, the thing that we want to call attention is the one that has the flag up the. It means that it has not been done and is accordance to the protocol. These are the exams that, if we don't use the protocol, if we use the routines, it will be made, and in our opinion, and the clinical proves that, was not necessary to be done. So in blood counts, we reduce 6.3% in exams, in coagulation tests 7%, and in biochemistry, we reduce 35% of complementary means that were asked. And if we translate this to less chemical reagents, less electricity that is waste, we can easily see that is a sustainability act. We also create a program that we call Waste Reduction in Cataract Surgery. This was the project that we present last year in Dubai, and which win a reward. In which win a reward. What do we know? Cataract surgery is one of the most common procedures performed worldwide. Over half of the emissions that originate by this kind of surgery is from disposable medical equipment. So what have we thought? How can we make something to change that? How can we bring some sustainability to this act and reduce disposable medical that we use? We know that in Portugal, almost in the last 20 years, the cataract surgery increased almost 1,000%. And in 2023, in our hospital center, we performed more than 4,500 cataract surgeries. So the change that we implement, we change the formulation of acetaminophen from IV to oral, and remove unnecessary fluids. Evaluating the weight of IV and oral formulation, the difference was about 19 grams, all made of plastic casing and tubbing. So what we pass from the left side of the old protocol with all this plastic to the right side of the protocol that only has one pill and the plastic bag. In the new protocol that we introduce, we take the device that is collected, put it with the IV catheter, and we use a new IV catheter that don't need that instrument, and reduce with that also the plastic that we use. We pass from the left side with the patient that is connected to that back support, to the right side that the patient is not needed to be connected, is more free and only with an IV catheter. This allows us to reduce 400 kilograms a year of plastic only with this surgeries. Translating this to not to only to our hospital center, but to Portugal, it will reduce almost 13,000 kilograms a year. In all Europe, more than 418 million kilograms a year. And translating this to green gases emissions, we reduce almost 1,250,000,000 kilograms of CO2 a year, only with the reduction of the waste that we produce, not counting with the production, transportation, and disposal of those plastics and the elimination. In the intraoperative period, we also create a more global project in our outpatient surgery center that we call eco-sustainability projects. What do we know? We know that 70% of the contribution of healthcare emissions is direct from the healthcare provider and the direct healthcare. So the trash, the waste that we produce, the disposable devices, the anesthetic gases that we use are funds of pollution. So what can we do to change that? We use the 5 R's: to reduce, to reuse, to recycle, to rethink, and to research. And we implement our program that is based on 6 pillars: the energy that we consume, the water, the anesthetic gases, the residue triage, the waste reduction, and the education for professionals. And I will speak of these 6 topics. The measures that are now in this slide have 3 different colors: the light blue and the bold. In the light blue, we are trying to call the attention to things that are easy to do and that don't make us waste money with that, but have a huge impact in the use of energy, such as turn off lights and equipment when it's not used. And this kind of project is so easy, but it needs to spread the idea in the workers and mind and brain, and try to every day create this policy in every individual. Turn off the HVAC equipment whenever the hospital facilities are not in use. Replace halogen and fluorescent bulbs with LED bulbs. And the hospital have already installed solar panels and other sustainability energy generators. Things in the use of water: we reduce the flush capacity of the toilet tanks. We use monitor water leaks, and in this outpatient surgery center, we install, and even in the main hospital that we have in Santa Maria da Feira, it is installed sensors in surgical sinks, not use too much water, and some simple acts like use water gardens during the early morning or late afternoon, or are some kind of acts that we're trying to implement in the global project. Focus more in my specialty, the use of anesthetic gases. What do we know? What can we do to do that? We can reduce fresh gas flows. We can use depth anesthesia monitoring, as bees, such as bees, employ alternative anesthetic techniques, not using volatile gases, but using, for example, IV anesthesia, intravenous anesthesia. Where if we want to use a volatile gas, we should choose sevoflurane instead of desflurane, and use gas scavenging systems. And this is other project that we are using in our local health unit. The recapture of anesthetic gases using a device that is called contrafluran. What do we know? I will try to be more rapid in my presentation, but I think it's important to explain. I don't know if you know how the anesthesia is provided, but I will try to explain briefly how it can be done. It can be done using the hypnotic drugs such by intravenous way or inhalation gases. And when we use inhalation gases, there are three types of gases that we use: desflurane, sevoflurane, and nitrogen peroxide. In the blue is desflurane, yellow is sevoflurane. Which are the advantages of volatile anesthetic compared to the other kind of anesthesia? It's easy of administration, quick on-off effect, lack of metabolization, and easy to titration. But it's not only advantages, it has also a big disadvantages. It contributes to global warming, and it's a red flag to us, knowing that, for example, it produces almost 0.1% of total world CO2 emissions, 5% of hospital CO2 emissions, and 50% of the emissions of the perioperative period are from these volatile anesthetic gases. For example, in trying to compare the gases, we know that the global warm potential of the gases, comparing, for example, desflurane, which this global warm potential is comparing to CO2. For example, desflurane is 8,000 more potential in 1 year to produce warm to the environment, comparing to CO2. For example, if we use desflurane 1 hour of anesthesia with 2 liters per minute of fresh gas flow, the use of desflurane it corresponds to come to the north of Portugal, to the bottom of Portugal. It's 675 kilometers of car travel. If we use a bottle of desflurane, 250 milliliters, it corresponds to come from our hospital center to Stockholm by car. And so once I am talking to people from Romania, from Lisbon to Bucharest is 309,000 kilometers. It's almost the emissions that we use with the use of 1 bottle of desflurane. This is just to make you look at the big picture of the use of this kind of gases. So which are the solutions? Reduce the fresh gas flow, use intravenous anesthesia, use regional anesthesia, avoid leaks, use monitoring the depth of anesthesia using EEG tracing, using sevoflurane instead of desflurane, and we capture anesthetic gases. This is what we are trying to do. We are using a contrafluran that is an instrument that collects the gases and avoid them to go to the environmental. And at this moment, it's not. We are not the enterprise that use that are not reusing. It's not possible to reuse, but I think that soon it can be. We can capture the gas and reuse again that gases with all the savings that is associated with that. So what have we done? We installed this kind of instruments in 9 of our 11 operating rooms. In January 2023 until December 2023, we recollect the gases of 521 desflurane bottles and 165 bottles of sevoflurane. And let me just make one call of attention. If you if you look to this kind of distribution, it's easy to know that the idea needs to be more spread, and we have to speak more about this with all the people, and the how important it is to change people, not change only physical and the hospital way of work, because in our hospital we're still using more desflurane than sevoflurane. If we say to everybody that desflurane is worse to the environment than sevoflurane, maybe this could be changed. It's one of our goals in 2024 is to go to the end of the year and see if this relation desflurane sevoflurane is changed. That makes us see that we are now coming to the people, and the people that work with anesthetic gases is really changing. In the residue triage, we also facilitate the access to recycled bins, reduce the number of group 3 waste bins, and we are training the professionals to the use of this kind of recipients. In the waste reduction, there's a lot of acts that are being done, passing for digitization and the end of paper, and the end of at least reducing the use of paper, the use of reusable equipment, and more clinical use, the judicious fluid therapy use. And this kind of, I talk about the cataract project, but I can also speak about ERAS programs that we are trying to implement in our hospital that lead us to use and to make a more judicious fluid therapy use, and prefer oral drugs to formulation. We are trying to implement new post-operative and protocols in acute pain, trying to introduce soon the oral formulations instead of IV formulation. And for example, in education and healthcare professionals, that we are well aware that is, I can't say that is the more important thing, but it's probably one of the most important things to do, is to create education of healthcare professional programs and make them believe and see the difference that each one acts made in the whole process. So we are trying to disseminate and obtain results, and trying to conduct educational lectures and make this kind of change of action. So we want to make fall this idea that sustainability is expensive. It's false. We know that, for example, sustainability is the same of savings. For example, in the USA, the implementation of sustainable measures can result in savings more than $15 billion in 10 years. And all this stuff, the idea that some people think is this is just create the waste of money, but it's not true. And ending my presentation and make a final statement, we know that we can change effectively. We can't oblige the people to change, but make. I don't know if you saw the movie Inception. In the movie Inception, somebody comes in the brain of other people and create them an idea and make them to believe that this idea is her idea or his idea, and they make the action. This is almost what we are trying to do. We are trying to spread the seed in the mind of each people that works with us and make them come to these projects, knowing that everybody counts, and that if people change, the hospital and the world will change. Thank you for your attention.
Thank you, Dr. Norbaba. Any questions? Let me stop sharing.
I wouldn't use the Inception example.
No, just the idea, not the total idea of Inception, the movie.
Their motives in the movie were not honorable.
Sorry, I don't understand you.
Their motive for doing what they were doing were not honorable.
Yes. No, I just want to use the idea of create a good idea in the people's mind and make them use that to change their way of act. Not the movie, not the thing in the movie. No, not the movie.
Can you stop sharing the presentation, please?
Yes. Sorry. Can I do that? Do it. It stopped.
And you are an anesthesiologist.
Yes.
And out of your own initiative, you took this on yourself, or you are assigned to be a warrior?
The Sustainability Warriors is a hospital project. I'm part of a team, and I can, what can I say? I'm in the hospital only 2 years until now. And once I came to the hospital, I realized that that is a very green policy in the hospital. The people is really dedicated to this. So the idea comes to me, and I'm the responsible for pre-operative evaluation of the patients in anesthesia. And I tried, what can I do to that? So we try in the pre-operative period, we create these two programs. And the other projects that were happening, are already running slowly, and the other people from my service are aware of this kind of issues and are very committed to that. So it's not, I don't see this as something that somebody told me to do. I realize that it's something that everybody is interested, and and my service is working on it. So I make part of the ship. I came to the ship, and I try to, I came there, and I think, what can I do to help this hospital to go forward with these projects? As I said, we say in the pre-operative, we sit and we think, what are we doing? What can we do to change it? And this is the main idea that occurs to us. But I noticed that even the main board of the hospital is really committed to this kind of issues. I don't know if I asked.
Unbelievable what you achieved, and when caring about the environment, it's also providing economy, and also it's in the benefit of the patient. Because in this way you can motivate unbelievers in the environment, because they can find motivation in the economy or the benefit of the patient. I mean, we all care about the patient first in the hospital. So yeah.
Yeah, I will give the example, and I'm trying to do this work also with my colleagues. For example, the introduction of pre-anesthesia consultation with teleconsultation. Initially, some of my colleagues think, oh, that's it, it's too difficult. Oh, the people won't understand that. I think it's not will be very useful. So what we are trying to do, we are trying to show the numbers that I showed to you, because people don't need to go to the hospital. people can stay at home and do their consultation. Lots of people lives far away from the hospital. People don't need to be out of work to doing that. We sometimes use only 5 to 10 minutes of the day, and they can keep working. And even to the environment, we don't need to car travels, less cars in the hospital, less people moving into the hospital. And I'm trying to show this kind of advantages to my colleagues, first of all, because I need to bring them to this idea. And now we are trying to spread this pre-anesthesia consultation with teleconsultation to more people in my service. And I try to show this also to the main board of the hospital, because less people in the hospital is less complication in the ground of the hospital, more cabinets that can be free, lots of advantages that I'm trying to explain, and trying to step by step showing this kind of situations. In the other projects, it's the same. For example, I am trying to, and being honest with you, one of the projects that is it's being difficult to introduce is the reduction of pre-anesthetic complementary means, because the idea of the preoperative routines is well established in Portuguese hospitals. So it's more difficult for us to choose the exams and give us more work when some patient come to our consultation, and we are looking to that patient and see, oh, this patient is high blood pressure, this patient has diabetes, so by the protocol he don't have an ECG, so I have to ask, and this brings in some cases more work. But what the work that we are doing is to collect this data and show if for one patient that this thing happens, we don't spend the money of 3,000 ECGs. It's better for us. In one patient gives more work, but in the other half we have more advantages than the disadvantages. So it's this work of demystify the idea of more work, more waste of money, and try to bring the people to the idea that in the beginning it can bring you some work, but it's much better for the hospital, much better for the patients, and much better for the environment. And I want to just end. I want to emphasize one thing, that is, none of these protocols, none of these actions were implemented if the security of the health that we provide to our patients isn't secure. For example, we read studies comparing IV to oral administration of acetaminophen in cataract, and no one says that IV is better than oral formulation. So we implement it. Okay, the use of sevoflurane instead of desflurane, they are both secure, but if we can use one instead of other, if this one it's better for the environment, if this one is less better or worse, how can we do to use more of this? It's a work that it's as I said, step by step we are trying to implement. It's difficult. We're not to do the inception of the movie, try to go in the brain of the people by this way, but make them see that this is not a fediver, this is not an important problem. This is a mission that we all have to do, and that bring us advantages as anesthesiologists and as human beings. What can I say? And I know if I explain answer to the...
Do you publish your work?
Yes.
It is already published, Dr. Nuno. Do you already have published that work?
No. I presented the work in the last in International Health Hospital Congress as a poster. but I'm trying to collect more data, make this more more juicy and more concrete, with more data to then try to publish these works. Yes, it's a project to 2024 that I create that we create in our service. Yes, we are trying to make this thing better and then show them and publish them. Yes. Sorry, let me just say this thing. What I understand is you love your work, not you publish your work. And I said, yes, I love my work. Sorry.
And we can see that's very good.
Sorry.
This is a good example of what I said before, that environmental sustainability is a responsibility from managers, top management, of course, introduce that culture, but also we need to give space to the bottom level also to propose initiatives and to drive the change in the organization. No? And this organization, I think it's the top one in Portugal because of their leadership and because they involve and allow the professionals also to propose and to submit their ideas and to give them the opportunity to make that happen. So it's a good example. And thank you so much, Dr. Nuno, for speaking of your experience with such passion, and to give us your example as a ruling model. And you must publish it, for sure.
Okay, I'll try to. Thank you for the opportunity. Have a nice day in Portugal, and bye.
And now we move forward to our last invited speaker. He is a dear friend and colleague. She's a hospital pharmacist.
28 years, more or less.
We worked several years together in the beginning of my career. And Rita is also passionate for how she can contribute to much better sustainable practice surrounding the use of pharmaceutical products. Rita worked in the private sector, in one of the major private groups in Portugal. We will visit this afternoon their new hospital in Lisbon, CUF Tejo. And today she will share with you some of the projects and the major driving ideas that she puts in place in their organization.
Okay. First of all, I'm sorry for my English is not the best one. My accent is not so good, so I hope to understand what I have to say. So I think you will be at CUF Tejo in the afternoon. Okay, so CUF Tejo is one of my hospitals. I'm responsible for the pharmacy of several hospitals. CUF is the larger private group in Portugal. So we have 3 main hospitals, then we have more or less 10 medium hospitals, and then we have a lot of clinics and so on. So we have some of these things that we addressed before implemented already, and we also want to do more. So I was, before beginning, I was listening up a while the discussion about the money and if you have hungry, first you have to have food, and then you can think about other things. It's the Maslow in the system. So, but sometimes we spend money, and I have that experience, also that data. We spend money in things that we shouldn't. For example, we can in hospitals centralize more things. We always are doing the same things in several places. In my group, There is some hospitals that specialize in some areas, other hospitals that are specialized in other areas. We don't have, each of hospitals don't have a laundry. There is one laundry for all. There is one food supplier for all. There is one negotiation center for all, because we can negotiate better if we are a huge group when comparing one or two hospitals. So there are certain strategic things that we can do to spend less money and then put the money in the other things, sustainability or other things. But we can do some small steps to lower the money that we spend with the things. And the medicines are a huge part of the problem, the financial issue of the hospitals and health system. So we all know the One Health concept, okay? We know that is a concept that recognizes the health of humans, domestic and wild animals, plants, and the environment. We all agree with that, but we have a problem. For example, the medicines are, and the thing related to medicines are emerging of a health crisis rising from the human, animal, and ecosystem interface. Maybe, we don't know for sure, but maybe the COVID was something related to that, maybe. But for example, AIDS is something related to this. AIDS came from the monkeys in Africa because we invaded their spaces. We began to eat the meat, and the virus came to the humans. So this interaction between environment and humans sometimes can bring us problems. And I gave 2 examples. So medicines are an environment concern. Residues excreted after consumption are a problem. Unused pharmaceutical medicines are a problem. For example, in our houses, we have a lot of unused pharmaceuticals. In the hospital, we have a lot of expired date validation pharmacies. So medicines are an environment concern. We know that there are certain groups that have been proven to cause adverse effects in ecosystems, including increased mortality in aquatic species and changes in physiology, behavior, or reproduction. We can work in prevention, reducing the used medicines in the environment. If I reduce the amount of medicines that I consume, if my hospital reduces the amount of medicine that is necessary to treat the patient, maybe, or for sure, I will reduce the unused medicines. It has a good side, financial good side, it has a good environment side, and it can give me money to spend in other things to promote the equity of the health, to bring health to the people in general. So interventions are recommended across all the life cycle of the medicines, the pharmaceutical products. And the household medicines waste are a huge problem. In Portugal, it is a problem. I don't know if Romania has this problem. For example, people who have syringes and something in the ambulatory that has in-house, for example, insulin syringes and something like that, they don't know where to put on the waste. It is a huge problem. Sometimes they put in normal waste. Sometimes they go to the pharmacy and give to the pharmacist. They don't know what to do. There is something that we have to do, work in education here in Portugal. This is an example. Other, the inhalers, for the asthma and so on, people don't know what to do with the devices. The majority goes to the waste, the traditional waste. It's wrong. It gives the medicines to the environment. So there are some things that we can do without spending lots of money, because this is all education, and have, for example, in the pharmacies, the infrastructure to receive those kind of waste, medicines waste, and give to the proper firms to treat the waste. So what we can do? Promote rational medicines consumption, and this is very important to spend less money. This is true for the community, this is true for the state, this is true for the public sector, for the private sector, for our financial money, our money. It's important to the environment, it's important to give money to other things, it's important to so many things. So less but better consumption of medicines, less and better. Give the medicines to the right patient, not give the medicines for all the patients. For example, I don't know if it's a problem in Romania. In Portugal, I have some medicines that my physician prescribed me. I go to the hospital, for example, to do small or big thing, surgery or something. When I go out, when I go again to the community, the physician will prescribe me another pharmacy products, another medicines different from the others that I have in my home. The state will pay for a part of the new ones, already paid for the ones that I have in home, and the state is spending more money. I'm spending more money. I have more medicines, and sometimes my needs are fulfilled with the other medicines that I have in home. Do you understand what I mean? So this is money, this is waste, this is less health, it's not better health for this. This is something that we can promote. We say in pharmaceutical science, it's a reconciliation medicine.
We understood yesterday.
I don't know if we have many time.
Sorry, I know.
No, it's not a problem for me.
That this is the job of the
pharmacy
practitioner.
What? Because
To put together the two.
But for that, you have to have a good system of communication that we don't have yet in Portugal. We are now getting better and better and better in this.
So yesterday at
Okay, thanks. So it's important to communicate.
What happened in Romania, we had lots of patients who had to do analysis many times.
Yeah.
Because people don't know.
Yeah, it's the same.
I mean, doctors don't know if they did in the ambulatory care and they come back to general practice from the hospital. That's waste of money.
Yeah.
That's also with medicines. Sometimes, and this is a little bit more complex in Romania, they go to 4 or 5 doctors and they have many prescriptions. And if you look at the prescriptions, sometimes they come to us, most of them they come, it depends on the kind of patient. And you see there are similar medication that you should remove part of the medication. So,
yeah, but it's the same here.
Sure.
I was reading yesterday a small notice paper that a couple, the old couple in the north of Portugal, in Portugal, matters north or south, they don't have money for the medicines of the woman and the man. So 1 month she buys the medicine, the other month she buys the medicine. Because they don't have money to buy all the medicine for both. So why? Probably, first, they don't need all those medicines. Second, probably they have at home medicine that can replace the new ones. Okay? This is money, this is state money, this is people's money, this is environment, well, it's all. Okay.
In Portugal, as you may see yesterday, when you visit the healthcare center,
No,
USF,
family care.
family care center,
Right.
all the medicines prescription in Portugal are made electronic. So we have an information system where all the prescriptions are made, but the physicians, not all of them have access to all the pharmaceutical profile or story of the patients. So that happens with medicines, that happens with exams that they made, some of them several times when they are not needed. Well, that it's a problem, but I think the first step in Portugal is to use that data, that information, and allow the physician and all the healthcare professionals, include
pharmacists,
who have
ambulatory and
access to that
hospital.
information and explain the patient that, well, you are using this medicine, but maybe you don't need to use it, and talk with the physician and try
Yes.
to reconciliate the therapeutic alignment for each patient. And there are, I think, rules about that. There are in primary care also some projects, pilot projects here in Lisbon that also include the pharmacists from the, in this case, from the local health units, now that they are merged, that can work with the patients that are identified by the doctors to have that kind of approach, working with them and their families, because mainly they are older persons. So sometimes they have a box or lots of medicines that they use without knowing if they are using correctly or if they are duplicated.
And we don't have it in Portugal. I bring that examples. We don't have in Portugal the concept of circular economy regarding medicines. That, for example, the Nordics have. Sometimes a medicine is good, it's valid, and I just take 10 pills, and the box is 50 or 60 pills, and I throw it away, and it can be used to another person. Okay, the Nordics have that. Here we don't have. Oh no, because we don't know how the other patient keep the temperature and the things related to the medicines and so on. So moving on.
Each one of us have a stock of
Yes.
So I heard the discussion, but I'm not very aware of the project. But last month there was project. I don't know. Maybe it was even adopted. Expired medicines to be taken to the hospitals.
It's already done. Sometimes separate.
So population, yes, and I think it was very superficial.
Here in Portugal, we can take to the ambulatory pharmacies.
Yes, so
Okay.
take them to the hospital, and the hospital should
Yes.
dispose of them free of charge.
Yes.
And it's
The
a cost
problem
to the
is we
hospital.
do not have a legal system to
So
the legal
state
system.
budget will pay for this.
Yeah, but we don't have the legal system for that. Sometimes happen that patient, especially somebody dies and
Yeah,
that remains
exactly.
medication. And sometimes not all kind of medication, sometimes
Yes.
remains more.
Cytotoxics and so on.
Sometimes people have changed their medication. They say,
Mhm.
look, I don't need this medication. So this is not a legal base, for instance, if you need to
Yeah.
take that medication to give it to other patient.
The Nordics are doing that, the Dutch people
Yeah,
are doing that.
sure, but you need,
Yeah, but they have the law to
We-
enforce.
Yeah, this is the problem.
Yeah, it's the
that's
problem.
the problem. So you have to have this kind of understanding because the fact it will really happen. You
Yeah,
don't
it's
know.
true, it's true. For example, in my hospital, we give the cytotoxic, oral cytotoxic to the patients. So who pays the patient or the insurance company or something because it's private. In the public sector, we all pay with our taxes. So, for example, if the patient dies, sometimes they bring us a box that is worth 2,000, 3,000, 5,000 euros, and I don't know what to do with that. And that is good. Sometimes I ask for permission and I take that. Sometimes I take that medicines and make a donation to other country, to Portugal, because we are always giving to the others, but we also need very, very much. No, it's true, because sometimes we like to give to the others, but we need also. So it's not just Africa, because we have people that also need donations. So if there is a huge things to do that we have to have the law by our side. So we have to change the law. And I believe in power of the community to change the whole. And for that, we have to have education. We have to be, and we have to be more demanding of the politics.
Well,
okay.
Actually, in Portugal right now, the legal framework doesn't allow to have a second utilization from pharmaceutical products that are dispensing by both hospital pharmacies or ambulatory pharmacies. So if a patient will return to the pharmacy and deliver what they have at home, the pharmacist can reutilize it. That they can accept it, but they move to the to garbage, to the incinerated processor, or any of the procedures that they are allowed to do. Because
but we are a rich country, so we are a rich country, so we can allow it. So the Dutch and the Nordics are poor.
Well, the same with the medicines that are expiring. I also have a degree in pharmacy, so I use it by my auto decision.
Yeah.
But in an institution, you can make.
And it doesn't stop at the midnight of the 30. Midnight will stop. I'm not valid for anything.
One thing there, like, the most frequent cars in Albania.
Was it?
Mercedes.
Oh, yeah, but that is typical of the south of Europe and Mediterranean and so on. So it's our country. We like to share, we like to spend money. It's the same. Portugal, Italy.
They don't have roads, they have.
Yeah, but they have Mercedes. No. Well, the Mercedes have a good situation. So they have to. The Mercedes have to. It's the profit. But it's typical. It's Portugal, Spain, France, Italy, Romania, Albania, and so on. It's in the Mediterranean things and the rocks. So, prescribing greener drugs. What can we say about greener drugs? Drugs that we know that can affect less the environment. Okay, there is a published by the Swedish that gives a scale of the greener and more greener and less greener to the pharmacy. For example, we know that there are some medicines that don't go in, they will be destroyed in the environment. And there are other ones that will almost forever in the environment. So we can, with a scale 1 or 10, and let's prescribe more pharmacies that will spend less time in the environment or will be destructive by it. Okay, medicines that are benign and easily biodegradable, personalized medicine. This is also very important. Not all people need all the things. So what is good for me, it's not good for the other person. So personalized for the days of the treatment, not 60 pills. Now, if I have to take 2 pills a day for 10 days, it's 20 pills, not 60 pills. That is, once more, money spent to the state, money spent to our pockets, and bad for the environment. It doesn't allows nothing better. It doesn't put nothing in this health of the people. Enhance dimension of the pack sizes, prevent avoidable waste, proper collection and disposal of unused medicines, special attention to hospital and the health units, education, health professionals and the problem. Education, because it works. It takes time, but it works, and it stays forever. Education. So it's very important for all, not just for this topic. So, why are medicines and environment concerned? So we have a demographic, not a problem, a challenge, because we have old population, much more old people than younger ones. lifestyle changes, aging problem, increase of chronic disease. People live more, it's good. People live much more until the 80s, 90s, it's very good, but they will spend it more and they use more medicines. Availability of inexpensive generic treatments, it's also good because it's possible to access the medicine. That is a basic priority, basic right to access health, access medicines. So we have more generic treatments, are cheaper, so people can access more easily the medicines. That is a very good thing. Very easy access to drugs, but it is increasing medicine consumption. Medicines are also designed to interact with the living system and produce some pharmacological responses at low doses. So when I find low doses in the environment and stable, the chemical speaking medicines, I don't know which are the genotoxic effects, which are the cytotoxic effects, which are the toxicity, because they are designed to do something at low doses and for a while. So I don't know the effects on the animals, the plants, the water, and so on. So how can medicines enter the environment? For excretion, excretion, and improper disposal. They come to the wildlife and they have a bioaccumulative effects. Humans, animals are exposed to medicines by drinking water, ingestion in plants, fish, and meat. So we are one health and one less health. So we all are exposed to these medicines. They are listed like contaminants, okay, by the 2030 Agenda for Sustainable Development. They are listed like contaminants, and we know by data, scientific data, they can cause chronic toxicity, endocrine disruption in humans, aquatic life, and so on. So, and they also have a huge problem, bacterial resistance. It is a world problem. So why? If I throw away antibiotics for the environment, bacteria will be used to that, antibiotics will be resistant to that. So low concentration are the reason for the difficulty assessment of the toxic effects. When science studies the low doses and their toxic effects in human, animals, or aquatic species or plants, it's difficult because it takes a long time to see what low doses for a long time cause, but it's difficult to study. Medicines not being sufficiently explored for the long-term toxic effects. Certain medicine groups are special in the problem they can cause. Beta blockers, antibiotics, anti-cancer drugs, and endocrine disruptors are a big problem for the environment, are a big problem for the water, for the species, for the plants, and for us. Okay? There are other examples, but these are the main examples of the problems in the environment. So it's impossible to spare humans from nature, and we know that these drugs in the environment can increase mortality, they can produce physiological and reproductive effects. There is some data, scientific data. We were talking addressed that a while. We have to have big data, true data, scientific proof data to do something. If I have to change the anesthetic gases, I have to promote or to adopt that practice sustained in big and scientific data. If I want to stop the inhalers, for example, because they bring gas to the atmosphere, I have to read some good data, scientific data, and then take the position or take the action. So big and good data are necessary to take the decisions when concerned to the environment. So estrogens, mainly because of the birth control pill, are a huge problem in the environment. There are 1,000 millions of birth control pill practice in our world. So the steroids go directly to the nature, and this is a problem because every animal, every aquatic species are sensible to the estrogens, because estrogens are the main molecules of all the live animals. So it's expected that they will have some toxic effects in the animals and fish and so on. They are used to enhance the production rate of the meat. That is also a problem which medicines the veterinary are using in the meat production, antibiotics, steroids, and so on. So we can receive steroids for the by the water, by the meat, and several sources. And in the production of the meat, they use a lot of antibiotics and a lot of steroids. The animals to grow more quickly, to be bigger, to give more meat, to give more money, and always that circle. So serious adverse effects are expected if it accumulates in the environment, because they can perturb animal physiology and reproduction. And we already have examples, the problem in the fish reproduction caused by the estrogens on the waters. And there are scientific data about that. So estrogens as a pollutant are also linked to a higher incidence of breast cancer in human, and you can find that information in both scientific articles. Antibiotics, the resistance is a problem. Probably if they don't invent some new antibiotics, or probably in 5-10 years we don't have antibiotics to treat and to kill those multi-resistant bacteria. It's a huge problem worldwide. Some bacteria, we have in Portugal some examples, not a lot of examples, but we have a few examples of bacteria that are resistant to every antibiotics that we have. So it's not usual, thanks God, but we already had some examples of that. But we don't have any antibiotics in the world to kill that bacteria, because the bacteria is resistant to all the antibiotics. So they are in human medicine, veterinary medicine, and also in agriculture, in the plants, okay? Because bacteria also attack plants. So they are present in every natural, in animals, in nature, in plants and fish and so on. So in every part of the environment can contribute to increasing antibiotic resistance and toxicological effects. Also, antibiotic disposal practice in the home sewage system, for example, can bring environment threat to the public health. We have in Portugal, in Lisbon, a project that is made by the Pharmacy University of Lisbon and the water company that serves Lisbon, EPAL. They have a project that consists in the following. They are measuring the waters that come to the central of treatment of the residual waters from home. They are measuring the antibiotics, the estrogen, the antidepressants, and many medicines, and they found values of antibiotics, estrogens, antidepressants, and also anti-inflammatory medicines. They published that they found some toxic levels of those pharmacies, those medicines in the water. And there is no technique yet to take those residues, those medicines from the water, okay? In the stations, water treatment stations, they don't have a scientific method to take that away from the water. So we are always drinking water with antidepressive, antibiotics, and so on.
The original molecule or the method?
Both, because there is just always a part of the original molecule that we excrete without metabolization. So they found in both the metabolites and some original parts. They published that work. Antidepressives, everyone is taking antidepressives everywhere for now. Well, in Portugal is the second medicines more prescribed. The first one is anxiolytic. The second one is antidepressive. The first one is anxiolytics, lorazepam, bromazepam, something like that. And the second ones are the antidepressants. I don't know.
With all this sun.
We
Well, we have a problem with depression. Sometimes the money doesn't fulfill the needs.
Our first impression, how happy they are.
So they are taking it.
They have lots of sun, so they need to
Yeah.
take antidepressants.
It's sad because we suppose we have all the conditions not to be depressive. Yeah, it's true. But there are some, it's much better now, but the COVID pandemic didn't help. But there are some mental issues and mental health problems that during so many times people didn't have money to go to the psychiatry or the psychology support. Now, for a while, we have that for free. The state is promoting the mental health issue, and we have treatments in the primary care and the hospitals, and it's more easy people to go to the treatment without spending a lot of money. 10 years from 10 years to now, it's much better, and the last 2-3 years is much better. But we need much more. So.
Psychiatrists like to prescribe.
Psychiatrists is very expensive. We have two
And family
problems.
doctors also.
Yeah, we have
Yesterday. And prescribe.
yes,
Antidepressants.
yes, and they
Yeah.
prescribe a lot.
Yes.
Oh, they prescribe a lot.
They prescribe a lot.
And they renew the
Yeah.
rest.
Yes, and sometimes people don't need antidepressant. They just need, someone to talk, psychotherapy. And sometimes someone to talk, because we have a lot of old people that live alone. We have that problem. They don't have support, family support, they don't know who to talk and so on. And sometimes they just need psychological therapy, and now we have that in the primary care and so on. But, some years ago we didn't have. And the psychiatry, it's expensive. It's like the dental medicines. Now we are beginning to have that in the public system. But for a while it was all private. It's very expensive. So we are all connected in some problems. No, we're not alone probably. Or Europe, like you were saying, Europe is very different. Yeah, we should try to be at the same level in so many things and then do it in others, but no, we are not there yet. So antidepressives have been detected in urban and non-urban water systems. Aquatic animals bioaccumulate antidepressive, okay? And psychomedicines are generally present in wastewaters at subtherapeutic levels that can induce biological and toxic effects. This is also data, scientific data, recent ones. Non-steroidal anti-inflammatory medicines are also a huge problem because in Portugal, I don't know how it is in Romania, in Portugal we can buy them.
UCT.
Yes, without prescription. So everyone has a headache, everyone has something, they buy, they take. And it brings also health problems, okay? Because I take some medicines for a pain, head or something, and I have stomach problems, then I have another problem that is a cascade of prescribing. Many.
All those are OCT.
Yeah. For example, naproxen exposure in 60 days in the nature. It still remains 60 days, 2 months in the nature. Wants to do. Chronic ecotox effects can be related to non-steroidal anti-inflammatory. They are very resistant to biologic transformation because they have a stable chemical structure and they can lead to disorders in the organs of so many animals, vertebrates, and so on, also with scientific data. Anti-cancer medicines, EV, intravenous and oral medicines, anti-cancer oral medicines, they affect the ecosystem because what they do to the cells that are neoplastic cells, they also can do it to the normal and healthy cells, humans, animals, and so on. So they bring problems. And cisplatin is one of the most hazardous pharmaceuticals known, cisplatin. And it is a huge cytotoxic medicine used in the treatment of very handsome pathologies. So, how to mitigate those impacts? Prior to improve the elimination process of medicine, once they reach the environment, it's more efficient and rational to act at the source. So, greener surgical rooms, we talked about the desflurane, sevoflurane. In my hospitals, all of my group of hospitals, we don't use desflurane. We take that step more or less 1 year ago. We ended sevoflurane, we just end desflurane, just use sevoflurane. That is cheaper than desflurane. That is an example. Inhalers bring a problem because they give gas to the atmospheric. So we are trying to change to the dry powder inhalers, but they are much more expensive. So maybe we have to do something to the pharmaceutical industry to lower the prices, to promote the use of.
It is the same, let's say.
Effect.
No, not effect. Easy for the patient to use.
Yeah, it is.
It's
yes.
the same from the patient perspective.
But we have also another problem. I'm talking we have. I think it's a Portugal problem. I read in the net that it's a world problem. Sometimes the people don't know how to administer the medicines. So the amount that goes to the atmosphere is more than the amount that goes to the insides. That is education. That is give the people the attention and the time to educate or to help them to do it good, in a good way. Now we have some programs concerning that in the ambulatory pharmacies, that the pharmacist can give some consultation to patients to help them to take the medicines in a better way to improve their health and also improve the environment. Okay? But in ambulatory pharmacies, it is supported by the state. For example, some consultation that are being done by the pharmacies are paid by the state. Okay, we are reimbursed by the state.
We have a problem here with alimentary supplements.
Which problem?
I mean, in Romania, there's a
Excessive
huge
consumption.
excessive consumption of these alimentary supplements, they are called like this, but they are without any studies.
Yeah,
and
we
they
have,
present
yeah,
with
we have.
medical
Vitamin supplements with
Yes,
antioxidant,
and,
with no.
lots of plants that you don't heard of
Yes,
from
yes.
India and
Yes,
and
we have
it's
that. Natural medicines, natural medicines.
natural, yeah.
We
And
have
it's beginning to be a
Yeah, it's a
health,
problem.
a public health issue.
Yeah,
Because it's overconsumption over the counter, and
Mhm.
people believe what they are told.
Yeah.
And
the net,
they come
the
to me, and
internet.
it's natural, it's
Yeah.
not gonna hurt me because
But
it's
it's nat-
natural.
yeah, the poison is natural. And
Yeah, I tell them also belladonna.
Yeah,
You know,
the
it
snake
doesn't-
poison is natural. So,
Yeah, that's true, but it's also a matter
But
of
the
research,
advertisement
because you
is huge, yeah.
a matter of research, because somehow if something does not have any research,
No research what
there is no research.
No
Okay, you
research.
cannot say this is not good.
Oh,
It's just
Yeah.
not research.
That's-
It's not
But
research.
they use the trademark of natural products.
Yeah, sure, but
Can be on the
Yeah,
market
because they-
without
and
any.
they promote that
every
they can
regulation.
cure
You are
liver
very
problems,
right.
they can.
You're right. Even in our areas, we commercialize different plants used here by years and years with no research. And that's why, because it's traditional. So it's a lot of debate here, but if you, so probably if something come from other, I don't know how to do it, but you need some research.
Well, I
say
think,
this is not
I
good.
think we as doctors used to fought against traditional medicine, and poor people from rural areas, when they come, they are, I tried some teas, and you talk to them and you make sense, and
Yeah, what
and
we
you-
can say in the limit of our paradigm is we do not have any study showing this is good.
that is the problem. I think someone should take care of those
It is
problems.
a problem.
And
totally
in
unregulated,
Portugal,
yes.
the Infarmed, it's National Agency for the Health, it's like the European agency, it's the Portuguese one, that takes care of the medicines, the
Medical devices.
medical devices and so on.
But not
Doesn't
all.
have-
This is under agriculture. Ministry.
Yeah, it's the same,
You
it's
are
the
right,
same.
but if you go, it depends how far you want to go. Because if you do not have much research or studies showing that the food we eat is good or not. But imagine you'll have clinical trials to see if the cheese is good enough and so on.
Yeah.
Will be really, really expensive. So it depends a lot on how far you want to go.
We have other
It's a
health, public health problem that it's about the use of proteic supplements.
Yeah.
In the
Yeah.
gymnasiums and so on.
Maybe in the seven groups like gymnasiums. Older people that use that kind of supplements, our president is a huge consumer of proteic supplements.
I think
And they
he wants to live more, huh?
and he promotes them the use of the supplements. So
It's
that
sometimes.
kind of diet supplements also are a public health problem affecting some groups of population.
Sometimes the advertising is made in those programs, TV programs that the old people see and so on. And the afternoon, they put some advertising of those kind of
Yeah.
medicines.
Calcium
There
is
is
one
no
of them.
regulation also. Don't try to regulate.
There is a regulation. We have to improve that regulation, and I think we should respect more. Sometimes the problem in Portugal, or I think pretty in Portugal, we do have legislation, but we don't put it
Not enforced.
in action, okay? But we have the law, it's all well written, it's perfect, we have the law, but it's not happening. Sometimes we're not only health, in everything.
It's also a
It's not
matter,
a lack of laws, it's a lack of
I think it's also a matter of behavior. Sometimes tradition is more important than law.
Yeah. And we are also a country with the rural population, a city population, now with lots of immigrants population. We have a lot of immigrants, especially from Brazil, from India, Pakistan, Bangladesh, also from Ukraine, from Russia, Belarus, everywhere. From United States, they are coming to Portugal.
From Africa.
From Africa, from our
Portuguese
ex-colonies, and so on. So, but it's good. I like
Soft culture also have impact on the consumption habits and cultural mindsets and the responses to the offer that we have in Portugal.
So, literacy, education, educate and information campaigns, give some education, some knowledge about medicine waste, recycling programs, for example, for plastic papers. There are so many hospitals that don't have a recycle program, for example. Basic one, plastic and paper. Public and private. The private is not much better than the public. We have some good examples in the public sector. We have some good examples in the private. We have bad examples in the public. We have bad examples in the private. People that make the difference, not financial system. So redispensing the unused medicine, that's what I'm talking about, okay? The recycling of the medicines is important. The volatile anesthetics, it's been already addressed. So the desflurane and the sevoflurane, we have to change to the sevoflurane. The Portuguese Society of Anesthesiology will publish sooner or later a recommendation to not use desflurane and begin just using sevoflurane in the low doses. So this has been already addressed. The inhalers, okay, I was talking about that, the emission that they bring to the atmosphere. So the greenhouse gases into the atmosphere are huge, and we are trying to switching to dry powder inhalers. So International Pharmaceutical Aerosol Consortium is coordinating some actions to press the pharmaceutical companies to move on to our dry powder inhalers. Let's see. Eco prescription, consider the characteristic and the environment behavior of the medicine, not just the therapeutic thing, the cost thing, but also the environment. So let's put the environment in the analysis, the cost, treatment, and the environment effects. Example, Oxaspan is considered a good option for the elderly due to its suitable pharmacokinetic profile, but it is excreted and changed via urine and accumulates for decades without biodegrading. So maybe you should not use so much Oxaspan in the older people like we are using now in Portugal, and not only in Portugal. So there are some examples, some good examples, some things that have been implemented in Europe and also in other countries, not Europe. We are just always talking about Europe, but we can find good examples of environment concerns about medicine in Africa. We can find in America. We can find in so many countries that don't belong to the European community. You know? So we are good, but there are always also others that are good. So it is a problem that we are all addressed. Even China and even India, that bring us so much problem in environmental pollution, are also doing a lot, especially in China, are also doing a lot relating to the medicines and the environment problem. Okay. So The European agency has some documents about this, and this is always in the language of all the European members. So there is law, there is recommendation. Sometimes we don't have it in action, implemented. There are recommendations, the best practice to reduce the environment in all the life cycle, procurement, logistics, prescription, consumption, and disposal. We in the private sector have the possibility of choose the suppliers with some sustainability criteria, was talked about before. The public sector is more difficult. They are moving to that, but just the price. In the private, it's the price and the environment. The private sector, when goes to the banks to ask for money, they have to give the sustainability report. So there are some things pushing in that way, okay? Because if the private company goes to the bank, the health company, they have to give the sustainability data. They have to, the interest of the amount of the money, the interest is related to the green policies. So they have benefits, economic and financial benefits in green. And for finishing, there are some case studies, good ones, in some countries, Norway, for example, related to the antibiotics. Portugal, to the shared and central prescription that Miguel was talking about. All the physicians should prescribe electronically, so that data should be available for all the physicians, the pharmacists, the nurses in the country. There is a huge and very good example of communication, trying not to duplicate the medicines. Increasing environment health literacy in Europe. This is very important, health literacy. We have a lower health literacy in Portugal. Not related if people have been in universities or no. Generally, people have lower levels of health literacy. And we are now with some campaigns trying to reverse that. And for conclusion, NHS, it's a good example. The English people, now they don't belong to us. The English people have some very good examples because they began all of these steps some years before us. So they have some good measures to reduce the amount of the medicine that are prescribed, to reduce the environmental impact. They have a green attitude in the hospital. For example, there are some hospitals in England that people, they have agriculture crops in the hospital that provide food for the hospital. Yeah, it's quite interesting. They have carrots, they have onions, and so on.
Their own farm.
Yeah, their own farm, yeah. Nice. Because it's a culture. Huh? And the farm is, who takes care of the farm are the doctors, nurses, pharmaceuticals, the people of the hospital. It's their farm, so they are responsible for that. So climate change presents several health consequences for all, we all know that. There is urgent need for all sectors, including healthcare. We have to decarbonize. Medicines have an important impact on the environment. Priorities must be set for intervention because we can't, it is not necessary to do everything at once, but some measures should be planned and implemented step by step.
Thank you.
No.
Thank you.
The slides
We'll share the slides, Joanna will share with you. Questions, comments, final remarks?
those beta blockers in the beginning. You're talking about the beta blockers. The environment, beta blockers.
Ah, yes, I didn't bring that data, but I can. There are some reports that panolol, bisoprolols, and beta blockers relate to the nature. Yeah. If you want, you have my email. I can give you, because I belong to the Portuguese Council of Health and Environment. Professor Queiroz, the first teacher that talked with you, it's also.
It's probably already available.
No.
Oh,
We will share with you the presentation.
Thank you.
Don't worry.
Okay, so.
But it's Rita.Oliveira. Rita.Oliveira.
Come on.
email.com.
Okay,
You wanna
so.
tell us?
So let's try to do something about this. There are some other priorities. For example, access to health and access to medicines. Yes, access to food, access to education, so on. It's true. We have that in mind. We have that in Portugal, that problem, challenge, I say many words about that. But this is also a problem, and it can goes in, yeah, because sometimes we spend a lot of money in things that don't contribute, and we can spend that money in others that make difference. So we can't analyze one thing, and we can look to the other things. For example, if certain family spends less money in medicines because it's not needs so much medicines, the money they spend, they can go on vacation, they go to the cinema, they go to something that's related to health. Because the health, mental health, it's also related to the money that we have to spend to medicines and so on. So this is all connected. It's the social prescribing that you were talking about. He was talking about that. The social prescribing, I don't know if you are aware of this, so it's very important. Sometimes people, I was reading, just to finish, I was reading also, I noticed that an old lady, every day, called to we have a line, not the emergency line, it's a helpline. Hotline for mental. Every day, she was talking to someone just to say, good night, I'm going to bed. Every morning, good morning, I'm awake. Just for that. Every day. It was published days ago. Just loneliness. Just to say good night, just to say morning. I don't know if it is a problem in your neighborhood. Yeah, it's probably the should take anxiolytics, antidepressants.
ChatGPT will talk to us.
Yeah, that's our
Well,
population.
Thank you so much. We hope that this seminar gives you some framework and ideas what we can make and what are our responsibility as managers, as leaders in the healthcare sector. And Joanna will share with you the presentations, and anything you need or want, you can contact us for sure. Every one of the presents will be available to give you some support opportunities. Okay? Thank you. Thank you.
Okay. No, well, that might be something.
My name is